It didn't say it over here, so yeah. For right, they're gonna say it for regurgitation. TR allowed as a tricuspid area, MR often due to ischemic heart disease, post MI, MEP, LV dilation, and rheumatic fever. Uh, that's usually the one they test you on, because this one will lead to like other stuff too. And this happens in Marfan's, so remember that. Often due to RV dilation and either MR or TR, infective endocarditis. The dissection, aortic dissection, this thing was in MR. I mean Marfan's. It was either this or this. I don't remember right now. You can look it up, but definitely know that. Okay. Then mitral valve prolapse. So this is the one with the MC. Okay. So the mnemonic for this was just it's M. How do you spell it? MC for MVP, or MC for MVP, or MC MVP. Okay, left crescendo murmur with mid systolic click. So this is important to remember that mid systolic click is part of mitral valve prolapse. Why does it happen? It's late crescendo murmur with, so it's late crescendo because it's after it opens up, right? So late crescendo murmur with mid systolic click that occurs after carotid pulse. Best heard over the apex loudest just before the S2, usually benign but can predispose to infective endocarditis. It can be caused by rheumatic fever, chorda rupture, or myxomatous degeneration, a primary or secondary to connective tissue disease. MC due to sudden tensing of mid-systolic click is due to sudden tensing of chordae tendineae as mitral leaflets prolapse into left atrium. Chordae causes crescendo with click. Ventricular septal defect, again holosystolic. All the yeah, no, just the systolic ones. Systolic harsh sounding murmur, loudest at tricuspid area. Congenital. Larger ventricular septal defect have lower intensity murmur than smaller ones. Okay, and that takes care of that. Let me read from my notes. So for aortic stenosis, I have in senile aortic stenosis due to dystrophic calcification by cell injury and death. Endothelial and fibroblast death. Infant bicuspid aortic valve is ES and SOS. Yes, okay, that doesn't make sense anymore. Then for you also have slow and rising carotid pulse in this. You have mid-systolic murmur, fragmentation of the elastic lamella in the aortic media. Okay, that's just the pathogenesis. So if you want to remember that, it's fragmentation of the elastic lamella in the aortic media. Then you have gags in MVP. So you're gonna hear, and the sound sounds like lapadub, lapadub, lapadub. And dermit sulfate, dermatin sulfate. I wrote that way back when, but I don't remember anymore what that means. But I guess it's also part of pathogenesis of mitral valve prolapse. Oh, it's written in the old book. The MVP is found in Ehlers-Danlos and Marfan's. Okay. I don't know why they took that out from here. They should have put that in. So, okay. Marfan's and Ehlers-Danlos is found in MVP. I mean, MVP happens in these two things. And then, what was for this one? This one they wrote rheumatic fever for aortic regurgitation. Okay, so that takes care of that much. You have okay. You can have Downs, Edwards, Patau's, Torch, and Cry-Duchet syndrome. In all of these syndromes can have ventricular septal defect. Down syndrome, Edwards, Patau's, that's trisomy of 13, 18, and 21. Torch and Cry-Duchet, they can have VSD. Then I have water pulse. Demosit head bobbing, that's what it's called. Okay. Opening snap, Microsoft. Or opening systems. SLE, mimickers, left atrial is okay. MR is degenerative endocarditis. IHD, DR is okay. Tricuspid regurgitation, IVDA, Marfan syndrome, carotid, pulmonary hypertension. Acute AR is infective endocarditis. Chronic AR is bicuspid aortic valve and connective tissue disease. You'll figure this out. Just remember, and infective endocarditis is for AR, right? Bayer. If you remember Bayer, then it's part of the E. It's Bayer. Give me a second. Okay, so done with that. Cool. Now we're going to do my
action potential now. So there's phase 0, 1, 2, 3, and 4. This important thing to remember is that this is the one with calcium in it. Okay, this and this, but the skeletal muscle, they don't have calcium, right? So okay, so phase 0 is about intracellular sodium, so sodium coming into the cell, and that's going to create depolarization action potential, right? So depolarization is just a contraction, right? So contraction happens when it's depolarized, or depolarizing is called contraction, and repolarizing is when it relaxes. So relaxes, it's repolarization. So voltage gated sodium channels open up, it comes in. Then phase one we have after it reaches the threshold, and the channels are depleted, the sodium channels are gonna close down. Inactivation of voltage gated sodium channels, and then we're gonna get voltage gated potassium channels to open up. So when that opens up, potassium always leaves the cell. That's just the way it is. So when that opens, it's gonna leave. So the polarity that sodium built up with the potassium in the cell was positive, right? But now the positive ions, which are potassium, it's gonna leak out. So the polarity comes down. So the graph is gonna come down a little. Okay, that's why you have phase 1. So when you have phase 1, you after that comes phase 2. The potassium channel is still open here in phase 2, and this is called the plateau phase. So while the potassium is leaking, you're losing positive ions, but then you have calcium coming in as well. So that's going to balance out the leakage of potassium with calcium ions, which is 2 plus. So this is why you have, 1 potassium going out while 2 calciums coming in, like 2 plus. So that's why you have like a balancing out and even like maybe a little rise because of calcium. So a calcium influx through voltage gated calcium channel balances out the potassium efflux. Calcium influx triggers calcium release from sarcoplasmic reticulum, right? Remember that diagram I drew? So This is the cell. There's a calcium channel coming in here. So it comes in here, and then also there are sarcoplasmic reticulum, which has calcium in it, right? So when this comes in, it attaches to the calcium receptors over here, which causes the release of these calciums into the cell. Okay. Sorry. Calcium influx through voltage gated calcium channel balances out potassium efflux. Calcium influx triggers calcium release from sarcoplasmic reticulum, and myocyte contraction then takes place. This is called the excitation contraction coupling. It involves calcium and ATPs. Okay, so now we're at the end of phase 2. So what happens in phase 3? This is called the rapid repolarization. So relaxation stage is this. This is where massive potassium efflux due to opening of voltage gated slow delayed rectifiers or potassium channels, and closure of voltage gated calcium channels. So we have massive potassium leaking out due to the open voltage gated slow delayed rectifier potassium channels. Just basically the potassium channels are still open and it's leaking out, right? So that's what that is. But the calcium channels are closed now. Okay, so we got closure of sodium up here, sodium channels, and opening of potassium channel here, and then nothing about potassium so far, it's still open. But then over here at the start of phase 2 we have calcium channel open up. At the end of phase 2 we have calcium channel closing, and then it's going into phase 3 then. So throughout this thing, is calcium is not coming in and potassium is leaking out. That's why we have downward projection of this graph, right? The positive ions are leaking through. Okay. Then we have phase 4, resting potential, high potassium permeability through the potassium channels. Okay, so even though this was about voltage gated channels, even if the voltage gated channels are, right here, they're closed, the potassium channels are closed. Now we still have some that are not voltage gated, and they're still permeable. So you have high potassium permeability through the K channels. So there are K channels over here as well. There are some with that require ATP, but some that do not. So they can flow in and out willingly, I guess, or out in this case. Okay. Again, phase 0. It starts with phase 0 on here. Don't confuse phase 0 with this area. Okay, it's over here. Phase 1 is over here. Phase 2 is here. Phase 3 is closing of all the channels, but the potassium non-voltage gated, so just the normal, channels are still open for that. And then you have phase 4, which is the resting potential. In contrast to, okay, so we went through that. Occurs in all cardiac myocytes except for those in the SA and AV node. These are called the pacemaker action potentials over here. So that's over there. In contrast to skeletal muscles, cardiac muscle action potential has a plateau due to calcium influx and potassium efflux. Okay. Then cardiac muscle contraction requires calcium influx from extracellular cellular fluid to induce calcium release from sarcoplasmic reticulum. Calcium from outside comes in and attaches to this thing. So calcium comes from outside, attaches to the receptor here, that causes release of more calcium into the cell. Okay, so induced calcium release from sarcoplasmic reticulum. This calcium-induced calcium release. Cardiac myocytes are electrically coupled to each other by gap junction. Okay. Now we are doing pacemaker action potential. It occurs in SA and AV nodes. Key differences from the ventricular action potential include phase 0. upstroke opening of voltage gated calcium channels. Okay, so here the phase 0 is about calcium. Okay, there is no sodium involved up till like phase 4. Okay, it's all about calcium and potassium. Here you'll have sodium funny channels, but here you have calcium. Important to remember that. Here it was about sodium. Here it's about calcium. So, but phase 0 also occurs at the upstroke. Okay, so that's not changed. So upstroke opening of voltage gated calcium channels. Fast voltage gated sodium channels are permanently inactivated because of the less negative resting potential of these cells, results in a slow conduction velocity that is used by the AV node to prolong transmission from the atria to ventricles. Okay. So fast voltage gated sodium channels are permanently inactivated, so you don't have sodium here coming in. When they're saying this, it's we'll talk about it later. Because of the less negative resting potential of these cells. Okay. So results in a slow conduction of velocity that is used by the AV node to prolong transmission from the atria to ventricle. So that's why AV node conducts electricity at a slower pace than SA. Not that it conducts slower, I think it does. It was Park Avenue, something, that thing. We'll do that later. But just remember that phase 0 is about calcium. Then phase 1 and 2 are absent, and then it goes straight to phase 3, which is repolarization. So that's the relaxation one. Inactivation of the calcium channels and increased activation of potassium channels. So then there's increased potassium efflux. So now, since calcium plus potassium positive ones make this more polarity towards the positive, now we have potassium leaking, so it's bringing it back down into the negative, right? You're losing positive ions there. So phase 4 now. The phase 4 are slow spontaneous diastolic depolarization due to funny currents or IF. So funny currents channels responsible for a slow mixed sodium inward potassium outward current, different from funny channels. Different from intracellular sodium in phase 0 of ventricular action potential, accounts for atomicity of SA and AV nodes. The slope of phase 4 in the SA node determines the heart rate. Okay, so if this is faster, it reaches the threshold faster, then it's going to be a faster heart rate. If it reaches slower, then it's going to be slower. So some of the drugs that we have act on this phase right here to prevent or induce heart rate. Okay, so acetylcholine and adenosine, these decrease the rate, right? So if you have someone with supraventricular tachycardia, or supra tachycardia, just like above, like, I don't know, 140 or 60, I think. That's when it has to be above a certain number before you can give this. So this will decrease the rate of diastolic depolarization and decrease heart rate, while catecholamines increases depolarization and increases heart rate. Sympathetic stimulation increases the chance that funny channels are open and thus increase heart rate, right? If they're open more, and then the sodium's going to come in faster and initiate the threshold to have intracellular calcium come out of the will just come in and cause the action potential. Okay, so we'll learn about the funny channels more when we're doing the drugs, but just remember the difference between the two. So this one, phase 0, is about sodium. This one, phase 0, is about the calcium. That's majority of the time what they're going to test you on. uh, know about phase 4, that it has a funny current channel. It's just sodium channels and potassium channels, not just sodium. It's sodium inward and potassium outward, right? And this is the one that determines the heart rate, phase 0. Uh, Electrocardiogram. Okay, so this is what I was talking about. So don't they have a mnemonic here? They used to have a mnemonic here. Oh, there it is. Never mind. Well, okay. He parks at Ventura Avenue. That's what the mnemonic was. Okay. Electrocardiogram. Right. This is a pretty good photo. So conductive pathway. Conductive pathway, conduction pathway. So SA node is right there, right? It goes to the atria over here. Okay, when it does that, you get this rise, right? And then when you have this, that's the flat line, right? So when it basically what this graph is going to show is the lines going away or near the nodes, right? So when it's going from this node to this node, you get a rise, a positive line, okay? When it's going from this line, from SA node to AV node, since it's in the same place, you don't get a rise or a decrease in the markings, so it's a flat line. So because it's in the same chamber, it doesn't have to travel through. So when it's traveling through to the other atria, that's the atrial depolarization stage, right? Because this is the signal that's going to tell the atria to contract. Okay, so that's the SA node, and this is called the Bachmann bundle, and it's near the, or it's like right next to the pulmonary vein coming into the left atrium. So when it reaches the AV node, right, that's the line. So AV node to, I guess, the bundle branches, that's going to be, wait, the colors are not matching up, but this part is where the AV node sends its signal to the first part of muscle that's going to depolarize, right? Okay, so after that it goes into the septum right here, or whatever, muscular septum. It's called the bundle of His. So from bundle of His, then it reaches the myocytes, right? And this is the myocyte. So that's going to cause a little, when it's going upwards that way, that's the signal going downwards, I guess. And then when it goes into the myocytes, and that causes the upward rise because it's going, into the myocytes over here and the myocytes on this side as well. And then as it reaches here and then comes back up, when it comes back up, that's the downward projection of this line. And then it comes back up and then around. So since it's going this way, direction towards this way, that's the upward motion towards it. Okay? It's not important that you know the components of this. Just know that P is the atrial depolarization. QRS complex is the ventricular depolarization. Okay? And this PR segment is PR interval at the time from the start of atrial depolarization to the start of ventricular depolarization, right? So this segment right here, before this blue line turns red, because red line is what ventricular depolarization is, right? So that's why this thing doesn't match up, but it does, I guess, because this is where it starts contacting with the first myocytes. That's why I was going on about that. Okay, so again, SA node to atria to AV node to bundle of His, right and left bundle branches, and then Purkinje fibers, uh, and ventricles. Right, so Purkinje fibers and then the ventricles. Left bundle branch divides into left anterior and posterior fascicles. Uh, that's just left anterior, and then I guess you have one going to the back, which is the posterior fascicles. SA node located at junction of right atrium and superior vena cava. So that's superior vena cava. So that's where you have SA node. It's important to know this. They'll test you on that. Okay. It's the pacemaker inherent dominance with slow phase of upstroke. Okay. Then you have AV node, which is located in the posterior inferior part of the interatrial septum. Okay, so this is the interatrial septum right there between the two aortas. Atrium, and then it's going to be right there. This signal goes through the foramen fossa ovalis. Okay, that's where this thing travels through. And just remember that this AV node is on the interatrial septum. So SVC is for for SA node, and then this one is for AV node in the interatrial septum. Okay. So AV node located in the posterior inferior part of the. So remember that too, because I think they also differentiate between which part of atrium septum. Blood supply usually from right coronary artery. 100 milliseconds delay allows time for ventricular filling. Pacemaker rates. So fastest one is SA node, right? Because that's the one that decides it. So SA node, then AV node, then the bundle of His, and then the Purkinjes, and then the ventricles. So it goes just like that. SA node is the fastest, then the AV node, and then the bundle of His, then the Purkinjes, and then the ventricles. Okay, so speed of conduction is His Purkinjes. So this and that is faster than the atria, which is faster than the ventricles, because you can imagine ventricles are large, and the kind of ones controlling the ventricles are going to be AV, so that's going to be the slowest. Okay, so when they ask you a question about this, it's important that you comprehend what they're asking, and then they're going to give you some numbers, right? So the smaller numbers are the faster ones, right? So you gotta think about it. So don't rush into it just seeing a bigger number and you pick it, because they're asking about what's gonna be fastest. But the bigger number is not the fastest. The one that has the smaller number, because that's the distance. Like, how would I explain this? So say, because I don't have a question right now for it, but say this is the distance that the signal is traveling, right? So when they won't explain that this is the rate. So then they give you this, and then they give you maybe 0.2. Right? So obviously 0.2 is fastest, but then you have to, figure out that that's what they're asking. They're not asking about the rate, because you're going to think they're asking about the rate, but they're actually asking about the speed of conduction, which is different than the rate, right? So be careful about that. For the speed of conduction, this is a pretty good one that works. He parks at Ventura Avenue, but you can probably make your own one if that doesn't work for you. Okay. So P wave. Well, we're doing this now. That's atrial depolarization. Then you have PR interval. Time from the start at atrial depolarization to start of ventricular depolarization. Normally 120 to 200 milliseconds. QRS complex, ventricular depolarization, normally less than 100 milliseconds. QT interval. Okay, so I'll go through all of them then. So P wave is we already talked about that. PR interval we talked about that. Is the it's important to remember the start of atrial depolarization to the start of ventricular depolarization. Okay. Uh, then we have a QRS complex, which is the ventricular depolarization. These timings are not really that important if you just know what to look out for. But sometimes when you don't know, the timings do come in handy when you're looking at a ECG. But for steps, they don't make the ECGs too complicated, so it's okay. QRS complex, ventricular depolarization. Then you have the QT interval. Okay, so QT intervals ventricular depolarization, mechanical contraction of the ventricles, and ventricular repolarization. Then what's T wave? It's ventricular repolarization. That's what that is. Okay, so T wave is inversion. Okay, so that's the part where it's coming back. So T wave inversion may indicate a ischemia or recent MI. Okay. And J point is junction between end of QRS complex and the start of ST segment. Okay. So the ventricular depolarization and then the repolarization. So this part right here is called the ST segment. Here they give us the QT interval, not the ST. So this is the ST segment. Isoelectric ventricles depolarized. Okay. So I guess when it's going back, out of the backside, that's the one that's causing this. Isoelectric causes flat line, right? So that's what this line is. So up till here, it's the S, I guess, because it's going towards, like it has an axis upwards. That's where it's going downwards. And then this way, it's going to go that way. I don't want to confuse you with that because it's not important. They don't ask you about that. What they will ask you is this thing right here. Pacemaker rates and speed of conduction. And you should know what these waves are because they will test you on the waves. If you should know how to figure out if it's a techie or not. The way I do it, I count the boxes between the R's. So let's see. So you have a ECG, something like this, right? And then you can just count between the boxes. So 1, 2, 3 and a half, right? So when you have 3 boxes, it's usually 100 100 beats per minute, so BPM, right? So basically, if you have 1 box, it equals 300 beats per minute. If it's 2 box, generally it's 150 beats per minute. 3 boxes 100, 4 boxes 75, 5 boxes 60, and 6 boxes is 50 beats per minute. Okay, that's like bradycardia then. So that's how you figure it out. So now we can see if there's a tachycardia ECG. So this is 2 boxes. 2 boxes is 150, right? You just count the number of boxes. So 2 boxes 150. 1 box is 300. 2 boxes 150. Sorry, and 3 boxes 100. Sorry. So I think I messed it up. 1 box is 300 beats per minute. 2 boxes 150 beats per minute. 3 boxes 100. 4 boxes 75. Then 60. Then 50 for 6 boxes. Okay. You should know how to read that at least. All the other stuff is like you'll figure it out after. ANP, very important. This comes in a lot of systems because this is what controls the volume in our heart and body for that. So it's released from atrial myocytes in response to increase in blood volume and atrial pressure. It acts via CGMP. Uh, Remember what CGMP was? It's the one with NO in that diagram. This thing right here. So NO with guanylate cyclase, GTP, CGMP. It activates protein kinase G. Okay. So CGMP causes vasodilation and decrease in sodium reabsorption. Okay. So it decreases that. It causes vasodilation, decreases sodium reabsorption at the renal collecting tubules. It dilates afferent renal arterioles and constricts efferent arterioles. Okay, so what does that do? Just real quick, you have afferent coming into the kidney, right? It does that, and then it goes, and that's the efferent arterioles. So if you dilate this, right, this, you're gonna have a lot more blood coming through, renal blood flow. But if you restrict this, that means there's resistance. So what does that mean? The blood is gonna pool in this, right? In this area. And it's gonna create a pressure, and this pressure is gonna, push this blood into the tubules for it. Filter, not blood, but like water is gonna get filtered and all that stuff. Because wherever Na goes, water goes with it, and that's how this ANP reduces blood volume, right? Okay. So it dilates afferent arterioles and constricts the efferent arterioles, promoting diuresis and contributing to aldosterone escape mechanism. You should know what that is, but we'll do that in renal. But real quick, it's just, since you're losing this much, your renin's going to get activated, right? So when renin gets activated, what does it do? It activates angiotensin. Angiotensin activates aldosterone. And what does aldosterone do? It reabsorbs sodium and it excretes some potassium, right? So that's why you have the escape mechanism. Even though you're losing sodium, you're not losing so much that it's affecting your, osmolarity, like that. You have, just like that, ANP. You also have BNP. It's similar to this, but this one is released from ventricular myocytes in response to increase in tension. Okay, so similar physiologic action to ANP with longer half-life though. So this one lasts longer than ANP. BNP blood test used for diagnosing heart failure. Very good negative predictive value. Okay. So if you suspect, CMI or something, the first thing you're going to do is what? CKMB, right? Those are the cardiac markers for that. If this person is known to have heart conditions, then you're going to do CKMB plus BNP just to figure it out. If you know this person's still suffering through hypertension and all that, then this is something you will, ask to get as well. Baroreceptors and chemoreceptors. Also troponin, not just CKMB, but also troponin. Baroreceptors and chemoreceptors, so afferents and efferents. Okay. This is an important thing as well because they test a lot about your understanding on this whole thing. So I'll go through this, and if I feel like there's something to fill in, I'll do that. Receptors. So you have aortic arch, transmits via vagus nerve. Okay, so that's the aortic arch. This is the vagus nerve, 10th nerve. Okay, and this is an afferent one. Okay, so aortic arch transmits via vagus nerve to solitary nucleus of medulla. Responds to changes in BP. Okay. Just a sec. Let me add something here, and then we can just look at that. Decrease stretch and decrease barrel receptor firing. Okay. This leads to sympathetic response. Okay. And then when you have increase in stretch and barrel firing, it parasympathetic response. Okay, let's make this a different color. Okay, so that's just a guide, so we don't get confused when reading this. Okay, so this is afferent for aortic arch. Then you have carotid sinus, that's up here in the carotid. So carotid, you can imagine, is in your neck, right? So right before it enters the head, it splits into external and internal carotid arteries, right? And right before it does that, you have a carotid sinus. So carotid sinus, dilated region superior to bifurcation of carotid arteries, transmits via glossopharyngeal nerve to solitary nucleus of medulla, response to the change in BP. You have a question about this guy wearing a very tight collared shirt and then he's getting syncope. It's because of a stretch of this, right? So stretching of that causes what? Parasympathetic response, right? Because that means that your brain thinks that there's so much pressure in here that the vessels need to dilate to decrease this stretch. So it's what does dilation or relaxation of the thing is parasympathetic system, right? So that's why there's lower in blood supply basically, which causes the syncope, even though the person's not needing it. So that's why he feels that. If he was doing something that actually required, he wouldn't have the syncope, right? So that's where this comes in. So remember, that's because of glossopharyngeal and not vagus. For some reason, a lot of people pick this answer, but it's gonna be glossopharyngeal. Chemoreceptors. You have peripheral. Also, glossopharyngeal is typically known for the tongue and back of the throat supply of the muscles. Chemoreceptors, peripheral, carotid, and also this is also there in the back of the throat. So this is I think afferent efferent for gag reflex. Alright, back to this. So you have chemoreceptors and baroreceptors. Chemoreceptors is about the chemical. So with chemical, it's about carbon dioxide. With baroreceptors, it's about the stretch and the pressure. So that's what that is. Okay. you have chemo and barrel both at each site. So it's not like you only have barrel here and chemo here or anything. You have chemo and barrel at both the sites. Okay, so chemoreceptors, peripheral, carotid, and aortic bodies are stimulated by increase in uh, carbon dioxide, partial pressure of carbon dioxide, right? So that means there is a decrease in pH because this determines what the acidity, right? So decrease in pH is acidic of blood and decrease in PO2. So again, it's a closed system. If PCO2 increases, PO2 decreases, and vice versa. Uh, then you have, yeah, so less than 60. Then central. In central are stimulated by changes in pH and PCO2 of brain, interstitial fluid, which in turn are influenced by the arterial CO2 as age cannot pass the blood-brain barrier. Do not directly respond to PO2. When it has PO2, it's pretty chill, right? Like, yeah, we got oxygen, we don't have to worry about it. But when it starts getting CO2, it starts panicking because, like, why is the waste product not leaking out, right? Or going through? Like, imagine you have a trash day and then the garbage people, pickup people don't come. You're gonna start panicking, right? Okay, that now you have to deal with more garbage in your house. So PCO2 is a waste product, and brain wants to get rid of it, right? So central are stimulated by changes in pH and PCO2 of brain interstitial fluid, which in turn are influenced by arterial CO2 as uh, H ions cannot cross the blood-brain barrier. Do not directly respond to PO2, right? Central chemoreceptors become less responsive with chronically increased PCO2. For example, COPD, right? So in this case, it's like, okay, the garbage pickup people are not coming, right? So at first you're gonna panic for like a day or two, but then you're gonna get like tired of panicking, and then you're just gonna relax and it's like it's okay, whatever. I'm not even bothered, right? You're just gonna lie to yourself. For example, COPD, right? So then what happens is it then increase in dependence on peripheral chemoreceptors to detect decrease in O2 to uh, drive respiration. Uh, okay, so for central, uh, that's what it's about. Uh, then it starts going back to this, and because this one gets stimulated by increase in PCO2 and decrease in PO2, right? This one does not directly respond to PO2. It only responds to increase in PCO2, right? So that's why there's an increase in dependence of that and peripheral one for the central one in COPD. Hopefully that made sense. Baroreceptors, hypertension, decrease in arterial pressure will cause decrease in stretch and decrease afferent baroreceptor firing. Okay, so decrease in stretch and decrease in baroreceptor firing. Here, the brain's gonna think, why is there no blood in the vessels, even though there is blood, but there's no stretch, right? So what's it gonna do? It's gonna, do the sympathetic response, the fight or flight response. So it's gonna vasoconstrict and all that stuff. Whereas here it's about vasodilation. So vasoconstriction and all that stuff's gonna happen, right? So you have hypotension, so that is decrease in arterial pressure, decrease in stretch, which will cause decrease in afferent baroreceptor firing. Okay, so decrease in stretch means decrease in baroreceptor firing, right? This is important right here that you understand this. That's why I wrote this out. That decrease in stretch and decrease in baroreceptor will give you efferent sympathetic firing, right? Efferent sympathetic firing is the efferent ones coming in, like this dark green one, right? This one is parasympathetic. So this one's gonna come in. It's gonna go to the blood vessel to vasoconstrict, and it's gonna go to the heart to pick up the heart rate and stuff. Okay, so increase in efferent sympathetic firing and uh, decrease in efferent parasympathetic stimulation, right? So it inhibits this basically, whatever this is doing, because this one's the one that relaxes you, or you have parasympathetic response when you're relaxed. So it's gonna inhibit that. So this will lead to vasoconstriction, increase in heart rate, and increase in contractility, and increase in blood pressure. Why blood pressure? Remember B1. B1 acts on heart rate, contractility, and renin. It acts on kidney as well, so that as well. And BP increases because of vasoconstriction as well, and the volume increases as well. Okay. So important in the response to hypovolemic shock. Okay. Uh, yeah. So this is the thing that keeps you going and during hypovolemic shock. Carotid massage. So what is that? It's increased carotid sinus pressure. So increasing afferent baroreceptor firing. So you get increase in AV node refractory period. So when you have decreased firing, it's sympathetic. So what happens for the opposite? If you have increased stretch and increased baroreceptor firing, it's going to give you parasympathetic vagus nerve response. Okay, so carotid massage, increase in carotid sinus pressure, increase in afferent baroreceptor firing through glossopharyngeal nerve. Okay, not vagus, through glossopharyngeal nerve. So increase in AV node refractory period leads to decrease in heart rate and decrease in cardiac output. That's your parasympathetic response. Also leads to peripheral vasodilation. Okay, because that's what it means to have a parasympathetic response there, right? Can cause pre-syncope or syncope, right? So this is the one I was talking about. A person wearing a tight collar, he starts, it's so tight that it's actually giving him a carotid massage, right? And when that happens, he's gonna end up with syncope or pre-syncope. Exaggerated in underlying atherosclerosis, prior neck surgery, and older age. They also do this for someone who has SVT, right? Supraventricular tachycardia. They tell them to do a carotid massage, so it lowers their heart rate. Okay. Component of Cushing's reflex, triad of hypertension, bradycardia, and respiratory depression. Increase in intracranial pressure constricts arterioles. Okay, the Cushing's reflex, we come across it in CNS as well. They explain it much better there. But overall, it's the triad of hypertension, bradycardia, and respiratory depression. So why does this happen? It's the increase in intracranial pressure which constricts arterioles, right? Because of this, when this happens, we give 100% oxygen to the person, right? And intracranial pressure increases, or even in damage by itself. As a EMT, that's what they would do. For paramedics, that's what they would do. If they found someone with a head injury, they give them 100% oxygen. Okay, so that it's not just that; it's also because of respiratory depression. So that's why. Okay, so increase in intracranial pressure constricts arterioles, which leads to cerebral ischemia, right? Because they don't have the oxygen now reaching, so they'll have increase in the waste product, which is increase in PCO2, and this causes acidosis, so a decrease in pH, which causes central reflex sympathetic increase in perfusion pressure or hypertension, right? Because now the brain's trying to send signals to, get some blood in here and get this waste product out, so it's going to increase sympathetic reflex response. So this causes increase in stretch though, and then what's that gonna do? It's gonna do peripheral reflex baroreceptor, and then that's gonna induce your bradycardia, and that's how you end up with bradycardia in increased ICP. Uh, if this gets complicated, go back to this mantra, right? So decrease strength and decrease baroreceptor firing, sympathetic response. Increase in stretch and baroreceptor firing, that's parasympathetic. Because you'll remember if this is going to be stretched or not, but then you're not going to remember if this is, baroreceptor fire during stretch, or do they decrease in baroreceptor firing when they decrease in stretch. Okay, so just remember this whole thing. So increase in stretch and baroreceptor causes parasympathetic, decrease in stretch and baroreceptor causes sympathetic. Okay, now normal resting cardiac pressures, the values change from before. Okay, so this value changed, right? And these values, both of these changed, I think. It used to be 110 by 90 or something like that. Anyways, normal resting cardiac pressure, pulmonary capillary wedge pressure, PCWP, and mmHg is a good approximation of left atrial pressure, except in mitral stenosis when pulmonary capillary wedge pressure is more than LV, and diastolic pressure, PCWP, is measured with pulmonary artery catheter. Okay, so what this means, pulmonary capillary wedge pressure, it's basically just the pressure in left atrium. Okay, so right before it enters that, um, so okay, so right before it comes in over here, right? So this, and then this, and this thing, they look like wedges, right? Because of this empty spot right here. This, if you color this up, it looks like a wedge. Okay, so that's where the name, I think, comes from. Don't quote me on it, but it makes sense. So whatever pressure is created here, it's, oh wait, this is going into the lungs, sorry. So similarly, just like this, when it's coming in, the pulmonary veins, it's gonna make, arteries are coming in like that, exact same thing, and it makes this wedge, right? So that's why it's the same pressure as left atrium. So for clinical purposes, they're the same. So to check that, what do? They put in the catheter in the pulmonary artery through the left atrium anyways. Okay, so that's why this is a good approximation of left atrial pressure, except for in mitral stenosis when left atrial pressure is more than the left ventricle's pressure and diastolic pressure. Okay, so it's measured with pulmonary artery catheter, and you need to know what these are. So this is gonna, a pressure in right atrium is gonna be less than 5. In right ventricle is a little more, 25. Systolic and diastolic is less than 5. Right. Obviously, diastolic is gonna be whatever this is, right? Because diastolic is the filling stage. So whatever pressure the atrium gives is gonna be the diastolic for the ventricle. Similarly here, if it's 12 here, diastolic is gonna be 12 here as well. Okay, so it goes in. The systolic is what's gonna push it into the artery, right? So the systolic here is gonna be the systolic in the artery as well. Similarly, systolic here is gonna be systolic in the aorta as well. Okay, so it pushes in, and the diastolic is a little more than the, a little more than this. Although, why its diastolic is low is because you gotta remember that it's getting split, right? There are two sides to it, so it's halved, plus it looks big here, but actual chamber is like this big, and then this is gonna be your pulmonary artery, right? That big. So all this pressure going through here, that's what it is, and then it's getting split. So the resistance in here is also gonna take away a little bit of diastolic pressure. Okay, and then obviously it splits into like all these capillaries or like different pathways. Not important to know the whole thing about that, just know that these values. So 5, 25 by 5, 25 by 8 goes in, The capillary wedge pressure is anywhere from 4 to 12. It comes in but less than, 4 to 12, less than 12. That's going to be the diastolic for the left ventricle, so 120 by 12, and that's how you get 120 by 80 blood pressure in from the aortic arch. Okay, cool. Next. Autoregulation, how blood flows to an organ remains constant over a wide range of perfusion pressure. Okay, so organ factors determining autoregulation: lungs, hypoxia causes vasoconstriction. Okay, this is the only important one because all the other ones are going to vasodilate during hypoxia. And we'll learn about that in recipe. Heart, local metabolites, vasodilatory, that's nitric oxide, carbon dioxide, and decrease in O2. They're all gonna, vasodilate there. Brain, local metabolite, vasodilatory, CO2, we just did that. Kidneys, myogenic, stretch reflex of afferent arterioles and tubuloglomerular feedback. I don't remember this one. You have skeletal muscles, so local metabolites during exercise, vasodilatory, carbon dioxide, hydrogen, ion, and then you have adenosine, lactate, and potassium. Address sympathetic tone in arteries. Skin, sympathetic vasoconstriction, most important mechanism of temperature control. The pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilation. How much time left? 4 minutes. Okay. So, this is important to know about the lungs because this is the only organ where hypoxia causes vasoconstriction because it has 3 parts to it, right? And the apex part has wasted ventilation, and the base has the wasted perfusion part, right? So when you're exercising, everything becomes 1-to-1 perfusion and ventilation. So there's no mismatch there, right? In hypoxia, what happens is there is a mismatch. So when you have hypoxia, the brain kicks in and it tells the lungs to vasoconstrict the parts that are not getting oxygen because they're pointless. Things are not getting perfused there or exchanging gas there. So then the parts that do get exchanged, the blood flow increases through that area, and that's why you hyperventilate because you're trying to get in oxygen more into the bloodstream. That's why you hyperventilate. Okay. That's the only important one. All the other ones, they don't really ask about it. Just know the local metabolites during exercise. You have lactic acidosis buildup. You have carbon dioxide. You have acidosis, so wherever you have acidosis, you have increase in H ions. Adenosine is something you might not remember, so put an effort to remember that one. And then potassium, obviously, because it gets exchanged for H ions. Okay. Intracellularly, this one, then in acidosis, I think there's a shift of potassium intracellularly for exchange of hydrogen ions. Okay, so capillary fluid exchange. Stirling forces determine fluid movement through capillary membranes. Okay, so you have a capillary right here. There are 2 types of pressure. Okay, one is capillary hydrostatic pressure, and then you have hydrostatic pressure and you have oncotic pressure. Okay, oncotic pressure pulls the fluid towards itself, and hydrostatic pressure pushes the fluid away from itself. Okay, so when you have capillary hydrostatic pressure, it's moving the fluid away from the capillary, and when you have interstitial plasma or capillary oncotic pressure, it's pulling the fluid towards it. Okay, similarly, interstitial is just outside the capillary, so if you have increase in interstitial hydrostatic pressure, this one is moving the fluid into the capillary, and interstitial fluid oncotic pressure is moving the fluid out of the capillary, right? So capillary hydrostatic pressure pushes fluid out of the capillary. You have capillary here. This is the hydrostatic pressure going outwards. Okay, this thing right here. Okay. So if you have, yeah, this, I don't know how to read this, but I can explain this. So I already did that. It pushes fluid out of the capillary. Interstitial hydrostatic pressure pushes fluid into the capillary, right? Because this is from outside, so this is the interstitium, so it's going to push into the capillary. Then you have plasma oncotic pressure. So oncotic pressure is the one that pulls fluid into the capillary, because it's in the capillary. But if it was outside the capillaries, then it's going to pull the fluid outside of the capillary, because this is the interstitial fluid oncotic pressure, right? So the net fluid flow is just the Kf, which is the capillary permeability to fluid constant, and that times the capillary hydrostatic pressure minus the hydrostatic pressure of the interstitium. So whatever you have left over is the amount of pressure there's left, right? So say you have more here and then less here, then you're gonna have more hydrostatic pressure from coming inwards. But if you have more here and less here, then you're gonna have a positive number or whatever. Never mind. You just have the difference here, and then you subtract the oncotic pressure of the capillary and interstitial, and that's gonna tell you which way the net flow is. Okay. They won't test you on the formulas, but they will test you on your knowledge of this. They will test about your knowledge on your understanding about the pressures, and this is gonna come in renal a lot, in the glomerulus, when you have increase in renal blood flow, when you have dilated arterioles, and then afferent arterioles and constricted efferent arterioles in the renals, then what happens? The interstitial fluid increases, right? Or the capillary one increases, so then it pushes fluid out of the capillary into the interstitium. And then that's how that whole thing works. Okay, so Kf is capillary permeability to fluid, and then you have oncotic reflection coefficient, so measure of capillary impermeability to the protein. Okay. Edema, excess fluid outflow into the interstitium, commonly caused by increase in capillary pressure, right? That will increase the hydrostatic pressure. Increase in capillary permeability, so increase in Kf, which was the capillary permeability fluid. For example, toxins can do that, infection can do that, burns can do that, right? Infection causes what? Increase in neutrophils. Neutrophils cause permeability to increase, so that then can be transmigration and all that stuff as well. Then you have increase in interstitial fluid oncotic pressure, increase in that. For example, lymphatic blockage. And then you have decrease in plasma proteins, and that is nephrotic syndrome or liver failure. Liver failure because liver is the one that makes or synthesizes the plasma proteins. Nephrotic syndrome because it's the leakage of protein, so you get proteinuria in that. And then also if you don't have any eat that much protein, so malnutrition because of that. Okay. So if you just remember, hydrostatic pressure pushes, and then oncotic pressure pulls, and then wherever it is, so capillary, it's going to push the fluid out of the capillary. If it's interstitium, it's going to push it into the capillary. If it's plasma, again, it's going to pull into the capillary, and if it's interstitial, then it's going to pull out the fluid. Okay. We're on to pathology now. We're going to do the shunts. So congenital heart disease, right to left shunts. These are easy to remember because it corresponds with the number 1, 2, 3, 4, and 5. Okay. So what is right to left shunts? It's early cyanosis or blue babies, often diagnosed prenatally or become evident immediately after birth, usually require urgent surgical treatment and or maintenance of PDA. That's patent ductus arteriosus, right? So this is when you would give what? Prostaglandins, because prostaglandin keeps it patent. So the 5Ts, one, truncus arteriosus, right? So let's read about that. Persistent truncus arteriosus. This is truncus arteriosus fails to divide into pulmonary trunk and aorta due to failure of aorticopulmonary septum formation. So most patients have most patients have accompanying VSD. So this is why you would get mixture of both oxygenated and deoxygenated going into the system. Okay. Two, you have transposition. Okay. So truncus arteriosus. Let me just show you a photo of that. So this thing right here, right? So this it's supposed to divide between the two, right? This need to split, and then you would get different aorta and a different pulmonary artery. But here it didn't separate, so now you have both a right ventricle going straight into the aortic arch, right? Maybe a little going here, and then it's coming here, and then this will push in as well. But if it has VSD, then you get mixing of the two bloods as well, so it further gets saturated, like with deoxygenated blood. So then you get purple blood going through. That's why you get cyanosis. Okay. Then you have two for transposition, which is two switched vessels. So this is the one with closed system, right? Detransposition of great vessel arteries. So because of this, you would try to keep patent ductus arteriosus, because that's the only way you can get oxygenated blood going into the system, because right now it's a closed system. What this is aorta leaves the right ventricle, right, instead of the pulmonary artery anterior, and pulmonary trunk leaves the left ventricle instead of the aorta or the posterior. So separation of systemic and pulmonary circulations not compatible with life unless a shunt is present to allow mixing of blood, right? So VSD would do that too. That would cause mixing of blood. PDA would allow some blood to go into the oxygenated blood to go into the system as well, or patent foramen ovale. So that's between the atriums. That will also allow that. Due to the failure of the aorticopulmonary septum to spiral, okay, so egg on a string, appearance on chest X-ray. So that's what it looks like, an egg, right? So without surgical intervention, most infants die within the first few months of life. Okay. 3, you have tricuspid atrasia. Okay, so tricuspid atrasia, absence of tricuspid valve and hypoplastic right ventricle, requires both atrial septal defect and ventricular septal defect for viability. Okay, so that's just absence of tricuspid valve and hypoplastic, because there's nothing to do, right? So what happens when a muscle doesn't work? It gets atrophied, right? So hypoplastic right ventricle requires both ASD and VSD, because then this way it's gonna go from right atrium to the left atrium, then left atrium to left ventricle, and left ventricle to the right ventricle to go into the pulmonary trunk, right? So that's why you need both ASD and VSD for viability. Then you have tetralogy of Fallot. This is a famous one. You should definitely memorize this one. Caused by anterior superior displacement of infundibular septum. Most common cause of early childhood cyanosis. 1. So you get 4 things, right? You get pulmonary stenosis, you get right ventricular hypertrophy, overriding aorta, and ventricular septal defect, right? So the pulmonary stenosis is this one right here. So right ventricular hypertrophy is this thing right here, and then you have overriding aorta, right? So this is the aorta, and pulmonary trunk is going through it right there. So I guess that's what it is. Hold on. Overriding aorta, I need to check that one out. Yeah, okay. So pulmonary stenosis and okay, that's what it is. So this is the pulmonary trunk, this is the aorta, and then the VSD is right here, right? So when this thing pushes, it can go from here or it can go from here, and there's mixing of blood here as well. Okay, so that's what the overriding is. This thing is just too farther down, but you know, essentially what it is that through the VSD it can go straight out as well. So to prevent that, what you do is squatting, because squatting does what? It does two things. It increases preload because it's closer to the legs, so legs venous return is increased, but it also creates a problem for the aorta because it increases systemic resistance, right? So systemic vascular resistance increases, so that will cause what? It will decrease this right to left shunt, and it will give some power because of the resistance to the left ventricle, because now instead of going through this, it's going to go through here. So now instead of going from here to here, it's going to go from here through here, because now there's resistance here, right? So it's going to go from here to here, and then now what's going to happen when this one goes and this one's pushing back, right? So it can't go through the VSD, it's going to actually go through the pulmonary trunk this time. Okay, and this is why people with or kids with tetralogy below, they squat and to make themselves feel better. Okay, so let's read this now. Caused by anterior superior displacement of infundibular septum, most common cause of early childhood cyanosis. Pulmonary infundibular stenosis, most important determinant for prognosis. Right ventricular hypertrophy, boot-shaped heart on chest X-ray. Remember this because they might just give you a photo of this, and don't confuse it with this one. Okay. Pulmonary stenosis, overriding aorta, and ventricular septal defect. Pulmonary stenosis forces right to left flow across ventricular septal defect, which causes right ventricular hypertrophy. TED spells. This is important because they will describe what TED spells is, and they won't tell you that it's spells. It's often caused by crying, fever, and exercise due to exacerbation of RV outflow obstruction. Okay, so that's what causes TED spells. It's described as the baby or infant having cyanosis when they cough or cry or something like that. Right. So again, it's squatting increases systemic vascular resistance, decreases right to left shunt, improves cyanosis. Associated with DiGeorge syndrome. This is DiGeorge syndrome, 22q11. Okay. Then you have number 5, TAPVR, 5 letters, right? So that's total anomalous pulmonary venous return. Pulmonary veins drain into the right heart circulation
and superior vena cava, coronary sinus, etc. Okay, so pulmonary vein, SVC, coronary sinus, etc. Associated with atrial septal defect and sometimes PDA to allow for right to left shunting to maintain cardiac output. Let's look up a photo of this. Okay, so the pulmonary vein is coming in and it's going into the, okay, so it's going straight into the superior vena cava. That's what it is. Instead of going into, you know, the left atrium, it's going into the superior vena cava, and it's mixing with the deoxygenated blood, and then that's the blood that goes into the this part, and then it's going back in. Where's this blood coming from? Oh, okay, ESD. That's why. Got it. Cool. So it's associated with ESD then. Okay. And sometimes PDA to allow for right to left shunting to maintain the cardiac output. Okay. Epstein anomaly, displacement of tricuspid valve leaflets downward into right ventricle, artificially atrializing the ventricle, associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. So we already went over this, but I'll show you the photo for this as well. Happens because of lithium. So now you have, normally this is where it is, and now it's down here like that. That's truncus, but yeah, everything else is similar. Left atrium, left ventricle, aorta is right there, pulmonary artery is right there, and this is the right ventricle. So you see how big the right atrium is compared to the right ventricle. Normally it's the other way around, right? So atrializing, sorry. So displacement of tricuspid valve leaflets downward into right ventricle, artificially atrializing the ventricle, associated with tricuspid regurgitation, accessory conduction pathway, and right-sided heart failure. It can be caused by lithium exposure in utero. Okay. Now we're going to do the left-right shunt. So it's acyanotic at presentation. Okay, so they look normal. Cyanosis may occur years later though. Okay, and that's how you remember this. So frequency is VSD more than ESD more than PDA. So right to left shunts, RL is for early cyanosis and LR is for later cyanosis. So if you have a cyanosis in an infant, it's not going to be one of these causes. It's going to be one of these causes, right? So you can just make an assumption that it's a right to left shunt by the cyanosis is happening. But if the cyanosis is happening in like a 20-year-old or something, it's going to be because of this. Sometimes they stay asymptomatic as well, right? That's possible as well. So, okay. Ventricular septal defect, asymptomatic at birth, may manifest weeks later or remain asymptomatic throughout life. Most self-resolve. Larger lesions, like that, that's where the septal defect is. So the blood from oxygenated blood from left ventricle is leaking into the right ventricle. So it may lead to left ventricular overload and heart failure because it keeps on getting more and more and more fluid coming into left ventricle, right? So eventually the muscles are going to give up and then it's going to go into heart failure. O2 saturation is increased in right ventricle and pulmonary artery, right? Because now
Normally it would have like a 2% oxygenation returning from the venous return, but now it's getting this added to the venous right ventricle. So the oxygenation of saturation of RV is now increased to like 10. Right? They ask questions like that. That there's ESD, so where would you see oxygen saturation increased in areas compared to a normal heart, something like that. Atrial septal defect is right there. That's because of failure of septum primum and secundum or something like that, not fusing together, so the ostium secundum stays open, right? Okay, so defect in interatrial septum, wide, remember wide for wiper, fixed split S2, right? So that was FA. Okay, ostium secundum defects, most common and usually an isolated finding. Sorry, I was just trying to remember what this one was. W was for white. It was pulmonary something, right? Yeah, pulmonary stenosis. And FA is for ASD, fixed ASD. Okay. S2. Ostium secundum defects, most common and usually an isolated finding. Ostium primum detects rare and usually occur with other cardiac anomalies. Symptoms range from none to heart failure, distinct from patent foramen ovale, which is due to failed fusion. Right? Okay, so what I said was wrong. Distinct from patent foramen ovale, so which is due to failed fusion. Okay, so this one is ostium secundum defects, most common and usually as isolated finding. Ostium primum defect rare. Okay, so it's about secundum. So they might ask you that. And atrial septal defect. They might ask you what's the most common defect and cause or most common cause of this. So it's a defect in secundum. This one is rare, so but other cardiac anomalies. Okay, symptoms range from none to heart failure. So everything can happen or nothing can happen as well. Okay. Now O2 saturation is increased in right atrium, right ventricle, and pulmonary artery as well. May lead to paradoxal emboli. Remember I explained that. Systemic venous emboli use ASD to bypass lungs and become systemic arterial emboli associated with Down syndrome as well. You have pain ductus arteriosus over here. In fetal period, shunt is right to left, normal. In neonatal period, decreased pulmonary vascular resistance, so it leads to shunt, becomes left to right, progressive right ventricular heart hypertrophy and or left ventricular hypertrophy and heart failure. Associated with continuous machine-like murmur, you need a patent for this machine. Patency is maintained by PGE synthesis and low O2 tension. Right, prostaglandin. So you give endomethacin to close this synthesis and low oxygen tension. Uncorrected PDA can eventually result in late cyanosis in lower extremities, differential cyanosis. Okay, so you need to know this right here. They will give you a patient who has blue toes, but not fingers, and then they'll tell you they did a Doppler ultrasound, and they found no thrombus or anything, because that would be your first thought, right? That there's occlusion somewhere, but then they ruled that out. So then you need to remember, okay, so PDA does this, and it usually happens later in life. So there are chances that it's PDA. So it's How do you get there? Is that because uncorrected PDA can eventually result in late cyanosis and lower extremities. Okay, PDA is normal in utero and normally closes only after birth. Eisenmenger syndrome, uncorrected left to right shunt, VSD, ASD, and PDA will lead to increase in pulmonary blood flow, which leads to pathologic remodeling of vasculature, which leads to pulmonary arterial hypertension. Okay, so basically what's happening is because of this, there was left to right before, but then that built up, that made this work more, and then there was right ventricular hypertrophy, and now there's right to left shunt instead of the left to right. So uncorrected left to right shunt in VSD or ASD or PDA increases pulmonary blood flow, right? Pathologic remodeling of vasculature, this is the problem right here. Pulmonary arterial hypertension, right? So that's what you get because of more flow. So right ventricular hypertrophy occurs to compensate, which leads to shunt becomes right to left when right ventricle pressure is more than the left ventricle pressure. So then, yeah, when this thing has hypertrophy, that's what happens. The pressure in right ventricle becomes more than the left ventricle. This causes late cyanosis, clubbing, and polycythemia. Age on onset varies depending on size and severity of initial left to right shunt. So that's why, yeah. So Eisenmenger, if you have VSD or something, you have to keep this in mind that it could be Eisenmenger. So what happens in that? You get backflow. When you get this and this pushes, it also actually pushes into this as well. So you could have tricuspid regurgitation because of VSD as well. Okay. Coarctation of the aorta, aortic narrowing, right there. So near insertion of ductus arteriosus, so this is just ductal, associated with bicuspid aortic valve, other heart defects, and Turner syndrome. Hypertension in upper extremities, lower extremities are cold with weak, delayed pulses, brachiofemoral delay with age, intercostal arteries enlarged due to collateral circulation arteries erode ribs. This causes notched appearance on chest x-ray. Complications include heart failure, increase in risk or cerebral hemorrhage, berry aneurysm, aortic rupture, and possible infective endocarditis. Okay, you know what? I think this is the last topic I'll do for today because I keep zoning out now and I think I'm done for the day. So we'll start tomorrow from 306. I'll finish this and we'll continue from tomorrow. So again, this is an important topic, coarctation of the aorta. Aortic narrowing happens, right? So that's this thing right here. Okay. Let's see the photo for this. Okay, so ductus arteriosus is here and coarctation is happening here after it. But if it happens before it, it's called preductal, and they both have different symptoms. So aortic narrowing near the insertion of ductus arteriosus, just a ductal, associated with bicuspid aortic valve and other heart defects and Turner syndrome. Hypertension in upper extremities. This is important, right? So why are you getting hypertension in upper extremities, right? And lower extremities are cold but with weak, delayed pulses. Yeah. Bicuspid aortic valve, it's actually right here, right here. The Turner syndrome. Which diagram? over here. Oh, that would be down here. So if you were looking at here, this is the bicuspid valve right there. All right. Yeah. Okay. So no problem. Okay. So where was I? Right. So hypertension in upper extremities. Why do we get that? So when you have, it's because the upper limb is supplied by these arteries up here, right? Uh, so you have 120 mmHg of pressure coming in, and it's getting pushed into these arteries, right? And you have 120, and these are smaller arteries, so you're gonna have more pressure in there compared to these, right? Even though it's splitting, it's this is known as the great vessel, right? So that's why you have a higher uh, systolic pressure in the upper extremities or hypertension because of that. And all the pressure then, whatever is leaking through is going to be less than whatever is in here, right? That's why you have different pulse. There's a pulse difference between the upper extremities and the lower extremities, because there's the descending aorta goes all the way down up to the iliacs and then it splits, right? So that's why hypertension in upper extremities. Lower extremities are cold with weak cold because blood is the one that provides the warmth from the core. With weak and delayed pulses, because the pulse doesn't reach fast enough because the blood is not reaching fast enough. Okay, and delayed pulses, brachiofemoral delay. With age, intercostal arteries enlarge due to collateral circulation. Arteries erode uh, ribs, right? So this is an important sign as well. So let me see if I can show that. Okay, so you're gonna get something like this, a photo like this, and then you gotta pay attention to this as well. They'll give you symptoms uh, that there are different. There's a pulse difference between the brachial and the femoral, and they'll tell you there's Doppler didn't even pick up any thrombus or something. Hold on. I'm gonna mute you for now, and then I'll unmute you after this. Okay. So they'll give you that, and then they'll give you that this is, sorry. Okay. So they're gonna tell you that the ribs they have cavitations inside or like linear erosion in it, and this only happens because of this. The erosion happens because of this. The cord, sorry, the vessels forming there, because since uh, the pressure is not reaching to those areas, they're forming new vessels to make collateral circulation. Okay, and this is what's eroding the ribs. So you have the notched appearance on chest X-ray. Complications include heart failure, increase in risk of cerebral hemorrhage because you have a lot of blood going back into the head, right? From the from here into the carotids, the common carotid to the stuff, and the head is not used to that much pressure. So, and you can have berry aneurysm, you can have aortic rupture, and possible infective endocarditis. Okay, I think that covers it. We'll look at a better picture for this though. So like that, right? They might give you an X-ray, or they might just describe it that the ribs are, they have some kind of thing going through it, or there's erosion of the ribs or something like that. They'll tell you that stuff. All right, I'll end it. Congenital cardiac defect associations. Uh, These are these come in handy when you gotta think quick for an answer if you remember these. So associations and defects: prenatal alcohol exposure, fetal alcohol syndrome, uh, ventricular septal defect, patent ductus arteriosus, and atrial septal defect, and tetralogy of Fallot. Right, almost everything you can think of in the heart, you can have it in prenatal alcohol exposure. Congenital rubella, you get PDA, pulmonary artery stenosis, and septal defects. Uh, Septal defects. So that's also VSD and ASD, PDA, and pulmonary artery stenosis. Okay. Down syndrome is AV septal defect, endocardial cushion defect, VSD, ASD, again, septal defects. Infant of patient with diabetes during pregnancy. This is important. Uh, Transposition of great vessels, truncus arteriosus, tricuspid atresia, and VSD. But they usually ask about the GIT system. You'll see that the infant has enlarged pancreas, I think. We'll do that in GIT. Marfan syndrome, MVP, thoracic aortic, and also the infant's gonna be large. It's gonna be big, large for his age, kind of thing. Marfan syndrome, MVP, thoracic aortic aneurysm, and dissection, aortic regurgitation. All of these are important because they'll give you like one of these things in the question stem, and then you gotta figure out that this happens in Marfan's. MVP is the buzzword for Marfan's, as well as dissection, aortic dissection. This one is iffy, and this one is iffy, but MVP and dissection. And then you have prenatal lithium exposure. Prenatal lithium exposure that happens, that causes Epstein anomaly. Turner syndrome, bicuspid aortic valve, coarctation of aorta. This one's important too. This one's with the bicuspid aortic valve, right? Normally it has 3 cusps. In this one you get bicuspid, and then you also have coarctation of aorta. So either of these should hint that it's Turner's. But they'll also give you that the patient has short stature, web neck, or something like that. Williams syndrome, supravalvular aortic stenosis. Let's check that one out real quick. Okay, so it's the ELF one, because you have Will Ferrell in the movie ELF, and this is the one with the Elfian facial features. Supravalvular aortic stenosis. Then you have 22q11 syndrome. That's the DeGeorge syndrome with the thymic dysplasia. DeGeorge syndrome. In that you'll have truncus arteriosus and tetralogy of Fallot. So tetralogy of Fallot, you can find it in alcohol and DeGeorge. Marfan's, MVP, mitral valve prolapse, and aortic dissection. When you have dissection, you probably end up with an aneurysm anyways, or vice versa. Then for Turner's, you have bicuspid aortic valve and coarctation of aorta. Okay. Hypertension. Persistent systolic blood pressure more than 130 mmHg and or diastolic BP more than 80 mmHg. Risk factors are age, increase in age, obesity, diabetes, physical inactivity, high sodium diet, excess alcohol intake, tobacco smoking, family history, incident greatest in blacks, then whites, and then Asian population. Uh, Features: 90% of hypertension is primary or essential and related to increase in cardiac output and increase in total peripheral resistance. Right? So we'll go to that. Remaining 10% mostly secondary to renovascular diseases such as fibromuscular dysplasia, characteristic of string of beads appearance of renal artery. So this is the string of bead appearance. If you see that, it's going to be this. Another place you'll see a string of bead is in vasculitis, pan. Right. So here you also see it in that same. That's the same picture, anyways, that they're using, but in this they use the same term. So it's buzzword. It's a buzzword for both of them. String of bead. So it's in here and in pan. Okay. Usually seen in adult females and atherosclerotic renal artery stenosis, or to primary hyperaldosteronism. Hypertensive urgency, severe, more than 180 or by more than 120 diastolic. Hypertension without acute and organ damage, right? So, and then you have emergency, formerly called the malignant hypertension. For this one, you need to know what it looks like because they might give you a photo of that. So that's what it looks like. Notice how there's only this much space left right now. You have hypertrophy of all the layers of an artery. Remember the artery anatomy that we looked at. So again, hold on, let's see. Like that, right? So you'll see an onion layer, and this is, you only see this kind of thing in a malignant hypertension. You won't see it in a normal hypertension, right? In normal hypertension, you only see like a hypertrophy of one of the layers. Okay. That's malignant. That's malignant. That's not an artery. That's glomerulus as well. Glomerulus. This is just one layer. You can make out the layer differences between the layers, right? So this is one layer right here. Then this is another layer. Then this is the third layer, the external or whatever. Anyways, whenever you see a sclerosing or like a onion layer, it's going to be your malignant hypertension. Okay. So formally called malignant hypertension. Severe hypertension with evidence of acute and organ damage, for example encephalopathy, stroke, renal hemorrhage, and exudate papillary edema. This is one of the giveaways. They'll tell you that there's like papillary edema or increased pressure in the eye or something like that. If you have retinal hemorrhage, you gotta look out for that as well. But this also happens in like diabetes kind of thing, so, but not the hemorrhage, right? Oh, okay. I guess that one's like more about the macular degeneration. So retinal hemorrhage and exudates, papillary edema, MI, heart failure, aortic dissection, uh, kidney injury, microangiopathic hemolytic anemia, and eclampsia. Arterioles may show fibrinoid necrosis. Okay. Predisposes to coronary artery disease, um, left ventricular hypertrophy, heart failure, atrial fibrillation, aortic dissection, aortic aneurysm, stroke, chronic kidney disease, hypertensive nephropathy, and retinopathy. So you need to know what hypertension can do to a body, right? Because it's very common, especially because in the packaged food uh, in first world countries, they always have a lot of salt in it to prevent, bacteria growth and to for the taste. So, hyperlipidemia signs, xanthomas, plaques or nodules composed of lipid-laden histiocytes in skin. Okay, so like that, especially the eyelids, like that. These are called xanthomas. Tendinous xanthoma, lipid deposition in tendons, especially Achilles tendon and finger extensors. Then you have corneal arcus. You'll get a photo exactly like this one, and then you gotta figure out that this is because of lipid, not because of something else. So lipid deposit in cornea, common in older adults. So this is called arcus senilis, but appears earlier in life with hypercholesteremia. Okay, so corneal arcus, tendinous xanthoma, xanthoma itself. Right, these are all signs of hyperlipidemia. Then you have arteriosclerosis. Okay, so they show it here. Hardening of artery. So this arteriosclerosis is different than erythrosclerosis because this one is dealing with the vessel itself, the artery. So it's the hardening of artery with arterial wall thickening and loss of elasticity. Arteriosclerosis, common, affects small arteries and arterioles. There are two types. There's hyaline and hyperplastic, right? So thickening of vessel walls, secondary to plasma protein leak into endothelium in essential hypertension or diabetes mellitus. So if you get a hyaline, let's see what that looks like. It's gonna be because of essential. Okay. Like that one. And this one counts as well. Okay. So the three layers, the tunica intima is okay. So the interior layer is the intima, then the medial layer is media, right? Tunica media, and then the last one is tunica externa. Okay, that's the anatomy. So in hyaline arteriosclerosis, you only have thickening of the intima, but in hyperplastic, you'll have it in the whole thing, and it looks like an onion, right? Like that, right there, or right there. Okay. Hyperplastic onion skinning. That's this one, and so you can see the difference between two. Here, it's only one layer that's affected, and this is all the layers, and they're essentially just smooth muscles, right? And muscles is basically something. If you stress it, it's gonna grow. That's why you do bicep curls and stuff, right? So similarly, if there's a lot of pressure coming from the blood flow, it's gonna push onto the artery. So initially it's gonna take it, but that's also gonna build up a little bit of resistance, and then it's gonna keep building it up, and then eventually it's gonna start doing it to the other layers as well. That's why you get the thickening. So hyperplastic onion skinning and severe hypertension with proliferation of smooth muscle cells. Then you have Mockenberg sclerosis, also called medial calcific sclerosis, uncommon, affects medium-sized arteries, calcification of internal elastic lamina and media of arteries, vascular stiffening without obstruction, pipe steam, uh, appearance on X-ray. So that right there. Okay. If you see that, it's gonna be Mockenberg sclerosis. So, vascular stiffening without obstruction, pipe steam, appearance of on X-ray, does not obstruct blood flow, intima not involved. Okay, so in here the intima is not involved. So pipe steam doing it, that just means like on a a chimney coming out, and then the smoke that you see, that's what it looks like. So you can think of a town, Mockenberg, up in the cold hills, and it has smoke coming through from the chimney, so something like that, I guess. Then you have cholesterol emboli syndrome, microembolization of cholesterol displaced from atherosclerosis. Okay, now we're talking about atherosclerotic plaques. Okay, so microembolism of cholesterol displaced from a plaque and from atherosclerosis in large arteries, usually the aorta, results in end organ damage due to small artery emboli and an inflammatory response. Okay, so you can get livedo reticularis. Let's look at what that is. Okay. Digital ischemia, blue toe syndrome. This is usually the one that you're gonna find on the test, because that's what it looks like. And like I said, the first thing you're gonna think of is thrombus or embolism, right? When you get a extremity gangrene or necrosis. So if you don't, if it's sinus by itself in the initial stages, and they tell you they did a Doppler and they didn't find any thrombus, what's it gonna be? It's gonna be this, right? Because remember, hypertension, lower extremities are cold and weak, and with delayed pulses, so it can have that cyanosis there. Okay, so first you're gonna think of thrombus, but in the questions then they'll tell you that they didn't find any sign of thrombus or anything. Then the next thing you go to is this. The coarctation of aorta. So acute renal failure, cerebrovascular accident, and gut ischemia. Pulses remain palpable because large arteries are unaffected. Okay, so they might even tell you this, right? That the pulses are there, but there's cyanosis. So that could apply to the other one as well, and this one. So you can't rule it out just because of that line. May follow invasive vascular procedures, angiography, angioplasty, and endovascular grafting. Okay. Majority of the time, you're gonna get a microembolization displaced from a plaque due to a fracture or accident in your femur. So if they say the person had an accident and fracture femur occurred, and then like 2 days later he has difficulty in breathing, it's going to be because embolism traveled up to the IVC into the RV through the pulmonary artery, and it got stuck there, and that's why they have difficulty in breathing. Okay. So atherosclerosis, very important. We need to know how this plaque is made. So it's very common disease of elastic arteries and large and medium-sized muscular arteries. Right. So elastic arteries and large and medium-sized muscular arteries. A form of arteriosclerosis caused by buildup of cholesterol plaques in tunica intima. Right. So in that one, it's because the muscles are getting big, and here it's because the layer under the epithelial lining or smooth muscle lining, endothelium, lining, there's cholesterol plaque buildup, which is causing the obstruction in the flow. So caused by buildup of cholesterol plaque in the tunica intima, the internal layer, right, of the artery. Location: abdominal aorta, most common, and then you have coronary artery, then you have popliteal artery, then the carotid, and then the circus of Willis. So from abdomen, you go to the heart, then the knees, then the neck, and then the head. Okay. Abdo, heart, knees, and neck, then the head. Okay. Risk factors: modifiable hypertension. So modifiable ones are the ones you can take care of, right? So you can, if you have atherosclerosis, you can take care of your hypertension, tobacco smoking, dyslipidemia, because it causes increase in LDL and decrease in HDL, and diabetes. Then the non-modifiable you can't do anything about is age, male sex, postmenopausal status, and family history. Symptoms are angina, claudication, but can be asymptomatic as well. Um, yeah, so the angina one is the important one. Will it will come when we do angina. Progression, inflammation important in pathogenesis. Endothelial. Okay, so here we go. This is the progression. Progressing. Why am I having a hard time saying words right now? So this is the pathogenesis. It's gonna start with the endothelial cell dysfunction. So you get like a break or injury or something in the endothelium, right? Then the macrophages and LDL is gonna accumulate there, right? So you have normal artery with the lumen, endothelium, smooth muscles, okay? And then you have macrophages coming at the site of injury or damaged endothelium. And then you, along with the macrophages, you have LDL lipid laden macrophages coming there, right? With the fatty streak and foam cells. So then it makes fatty streak formation, right? This is an important step too. Then you get the fibrous plaque formation. So here you have the smooth cells involved as well. Smooth muscle cells. So smooth muscle migration happens and the fibrous plaque is formed. And the layer over it is going to form as well with the endothelium. And that's why it gets stuck there, right? So that's the plaque right there. You can make out that this is a intima, this is the media right here, the pink one, right? And then you have this layer, the externa. So right in the middle, right in the intima is where it's, or right under the intima, I guess. You can see the plaque. But if they ask you a question, it's going to be in the tunica intima. Okay. Okay, so we have accumulation and then foam cell formation, then the fatty streak, then the smooth muscle cell migration involves prostaglandin derived growth factor and fibroblast growth factors, proliferation and extracellular matrix deposition, fibrous plaque, and then complex atheromas are formed and calcification occurs. So calcium content correlates with risk of complications. For this, there's a diagram on UWorld for this. That's pretty helpful. This one right here. Okay, we'll have to go to that one then.
we'll zoom into this. Let's see, we can figure it out. Okay, let's we can comprehend this. Okay, so this is the lumen, right? This is the intima layer of the thing, and then this is the media. So we have endothelium dysfunction, right? So there's some kind of problem there. You have macrophages there coming in, as well as LDL, and then the oxidized LDL gets taken up by the macrophage, and then that when the macrophage and LDL gets mixed, it's called foam cell, right? So lipid uptake of macrophages. So foam cell, then the foam cell will, along with the growth factors. The growth factors are which ones? These ones, right? PDF and FGF. Along with that, and the smooth muscle cell proliferation causes the fatty streak, right? So that's the fatty streak right there. So fatty streak is macrophage, LDL. So LDL laden macrophages, the fatty streak, and the foam cell. Okay, so it's just the foam cell formation causing the fatty streak, and then the smooth. Okay, so fatty streak happens before the smooth muscle cell proliferation. Okay, you have extracellular lipid and necrotic debris, smooth muscle cell migration, smooth muscle cell proliferation, and cholesterol efflux, or HDL. Okay. Again, we'll do this one more time. Endothelial cell dysfunction. Then you have macrophage and LDL accumulation, and then when you have LDL laden macrophages, they are called foam cell. So foam cell formation happens, right? Then you get the fatty streak. I just need to make sure what this is. Appears when the presence of foam cells at the site of plaque formation expands. At this stage, a lipid core has been formed that will progress into a mature atherosclerotic plaque from additional influx of different inflammatory cell types and extracellular lipids. Okay, so you have intimal T cell puts out the cytokines to make this, and then you have this. Even though we read this much about it, they always figure out a question that has to do with this, and it's something we haven't came across yet. I hate that. Okay, smooth muscle cell migration involves PDGF and FGF. You have then proliferation of the smooth muscles and extracellular matrix deposition. Right, so all of this will cause fibrous plaque. Complex atheromas, calcification, and calcium content correlates with risk of complication. The first cell that comes is macrophage, okay, not monocyte. So macrophage, and then the LDL gets uptake into the macrophage. Okay, aortic aneurysm. Done with atherosclerosis. Aortic aneurysm, localized pathologic dilation of the aorta, may cause abdominal and or back pain, which is a sign of leaking, dissection, or imminent rupture. This is a buzzword for it. A patient who's suffering from back pain. Okay, so that when you have back pain, it can be three things. One, it can be pancreatitis. Second, it can be this thing, aortic aneurysm. Third, it can be ankylosing spondylitis when it's in the lumbar region. Okay, so localized pathologic dilation of the aorta may cause abdominal and or back pain, which is a sign of leaking, dissection, or imminent rupture. Also, heart attack in females would give you back pain as well. Normally you hear about it on the chest, but it can be on the back as well. But for that, they'll give you an ECG or like some kind of CKMB or troponin markers.
Okay. Thoracic aortic aneurysm. So associated with cystic medial degeneration. So this is in the medial one, not the intima or externa. And that is being degenerated, right? Degraded, I guess. So risk factor include hypertension, bicuspid aortic valve, because normally you have tricuspid aortic valve, right? So when you have that, there's going to be more pressure, and so basically, okay, aortic valve, connective tissue disease, for example, Marfan syndrome. We did that, right? Also associated with tertiary syphilis, obliterative endarteritis of the vasa vasorum. And this is why in one of the questions they said that when a child was delivered, the umbilical cord had necrosis on it. It's because of syphilis. Syphilis will cause that. Aortic root dilation may lead to aortic valve regurgitation. Okay. So what's happening here normally? Try drawing it out. So when you have an artery like this, right, and there's like a breakage over there, and then you have a normal artery here. So this whole thing is a vessel. This is just one side of the vessel and the other side, and the blood flows through here, right? So sometimes when you have a little bit of a breakage or something here, the blood will go through here, and then every time the heart beats, a pulse comes and it pushes further and further, you know, into the medial layer wherever it was leaking. So it'll keep pushing this, it will keep pushing that, and this will keep going in, and that's how you end up with this medial degeneration of aneurysms. Okay. Actually, I'm talking about dissection, aren't I? I'm not talking about aneurysm. Never mind. Okay. So ignore that. Okay, thoracic aortic aneurysm, again, associated with cystic medial degeneration. So remember that. This is the pathogenesis of aortic aneurysm. The risk factor includes hypertension, bicuspid aortic valve, and connective tissue disease, for example, Marfan syndrome, also associated with tertiary syphilis, obliterative endarteritis of the vasa vasorum. So that's, what does that mean? Vasa is vessel, and vasorum is like around the vessel. So it supplies the great vessels, the capillaries or the capillary network or the artery network around the great vessels. So aortic root dilation may lead to aortic valve regurgitation. Okay, so if this leads over here, and then there are only two cusps of aorta, it's gonna cause this dilation over there, and that's how you get the valve regurgitation because of that. Because imagine this is affecting the layer here too, so that's going to affect the structural position of the valve as well, causing the regurgitation, right? Abdominal aorta aneurysm. This is the one in the descending aorta, right? It's associated with transmural, so all three layers, inflammation, and extracellular matrix degradation. Risk factors include tobacco use, increase in age, male sex, family history, may present as palpable pulsatile abdominal mass, arrows in A, point to outer dilated aortic wall, rupture may present as triad of pulsatile abdominal mass, acute abdominal or back pain, and resistant hypotension. Okay. This is also a main giveaway if they give you back pain with a resistant hypotension. Okay. Most often infrarenal distribution of vasa vasorum is reduced. So what do we have? Ascending thoracic aorta is this purple thing, then the aortic arch, then comes the descending thoracic aorta, and then you have the abdominal aorta here. So there are two types of aneurysm. You can get a fusiform aneurysm, that's like that, and secular aneurysm like that. Okay, that's what it looks like on an X-ray. I mean, on a scan, not X-ray. Let's see a few more. Okay, so this is sclerotic. This is abdominal aortic aneurysm, right? So you can see the difference between the two layers. This is the one with the blood, and this is the muscles of the artery or aorta. Okay, right there. Yeah, they'll probably give you something like that, right? So it's easy to figure it out. Traumatic aortic rupture. So it's due to trauma and or deceleration injury. Most commonly at aortic isthmus. That's the proximal descending aorta, just distal to the origin of subclavian artery. X-ray may reveal wine mediastinum. Okay. But if they give you a wine mediastinum, it's probably a sign of emphysema, because that's what they use that terminology for. They'll give you other stuff as well, traumatic for aortic rupture, like hypotension, going into hypovolemic shock and stuff like that, and then they probably find a little bit of bleeding somewhere, and then they'll ask you, where could this rupture happen? And then you gotta remember that the most common spot is the aortic isthmus, right there, around there. Okay. So aortic dissection, that's what that looks like. A longitudinal intimal tear forming a false lumen. So this is what I was explaining over there. And you can see that's here, and then so ascending and the descending as well. So it's going like that, and it's traveling from here, and it's gotten bigger over here. So longitudinal intimal tear forming a false lumen associated with hypertension, bicuspid aortic valve, inherited connective tissue disorder, for example Marfan syndrome, can present with tearing, sudden onset chest pain radiating to the back, with or without markedly unequal blood pressure in arms. You have chest X-ray that can show mediastinal widening, can result in organ ischemia, aortic rupture, and death. So you have Stanford type A, and then you have, which is the proximal one. It involves ascending aorta. A involves ascending aorta. So if it involves that, it's type A. May extend to aortic arch or descending aorta. Blue arrow in A. Okay. So this is the descending aorta. May result in acute aortic regurgitation or cardiac tamponade. Okay. Treatment is surgery. Stanford type B distal involves only descending aorta below left subclavian artery. Okay, so I'll draw that over here now. So you have a whole artery, right? That's the external layer. There's the internal layer of the artery. Again, it's a damage over there, and then you have one side over here. And this is like the
aortic valves over here into the left ventricle, into the heart. Okay, so when it pushes in, you have 3 cusps here, or maybe 5 cuspid because we have this thing. So maybe it got damaged over here, or there was somewhere a damage initially, and then the blood started pulling in over here. And then when you have like hypertension or something, or for any reason, the heart pumps harder, and then this keeps going inside and inside, and then that's where it pulls the blood. Okay. So what can you do to prevent this, right? You give beta blockers to slow this down, because what does beta 1 do? Increase heart rate, increase contractility, and renin, right? So we'll block this. So we give beta blockers so to decrease the heart rate and the hypertension rate. So when you slow down the heartbeat, what's going to happen? Even if this goes in, it's going to have a pulsatile action, right? Because it's pulling inside and there's blood here too, so it's going to create a little wave kind of thing. So you'll have this wave. So when you slow down the heart, before this wave comes back, if there was another wave, it would further damage this layer, right? So when you slow it down, this wave, before another thing comes, a pump, the wave is going to stop and it's going to disperse. So then there's not that much damage anymore. So we can give beta blockers, or what? Another thing we can do is we just make this wider, right? So there's a lot more area for this to go in rather than going into this, because then there will be resistance here compared to this area. Because remember, you're dealing with 120 mmHg of systolic pressure. Although vasodilators don't really have that much effect on the great vessels, but it will have it on the vessels that great vessel supplies to, right? So it will decrease the resistance, so it can go easily through the artery. So that's why, to decrease the total peripheral resistance, you give vasodilators and beta blockers. And aortic dissection. Aortic dissection is known for what? Marfan syndrome. Okay. That stuff. Okay. Subclavian steal syndrome. This is also an important topic. Stenosis of subclavian artery proximal to origin of vertebral artery, hypoperfusion. Okay, so this is right vertebral artery right here. This is the left vertebral artery. We'll do this in near circle of Willis. We'll talk about the vertebral arteries there. But for now, this is the vertebral artery coming in, right? And it attaches to proximal left subclavian. So subclavian artery. But right before it, the attachment of that on the subclavian, there is a little bit of pinching over there. So, or stenosis. So stenosis of subclavian artery proximal to the origin of the vertebral artery. So this is the origin of vertebral artery. So normally what's going to happen in artery, it goes into, right? It always goes into and away from the heart, right? Like that. But because of the stenosis, that's not happening. It's not going into the vertebral artery here to supply it. Instead, you're getting blood coming back into this from the other side of the stenosis and going into the system, right? So that's what the subclavian steal syndrome is about. It's stealing the blood from this side to supply this side of the body. So what's that going to do? Leave less blood for the brain, right? Normally it would have supply from here coming into the brain and from here into the brain, but because of this, it doesn't have enough supply in the brain, because when it comes up here, there's less resistance here because there's literally no blood on this side, right? So rather than pushing into the brain, it comes onto the side of resistance, right? Okay, so I'll read that again.
Stenosis of subclavian artery proximal to origin of vertebral artery. This will cause hypoperfusion distal, so that would be distal away from the core, to the stenosis. So this will cause reversed blood flow into ipsilateral vertebral artery. Okay. So instead of going this way, it's gonna cause this way, ipsilateral. So ipsilateral is the same side of the stenosis, on that side. Okay. So reverse blood flow into the ipsilateral vertebral artery. It's coming into the artery now, rather than going away from the artery. This will cause reduced cerebral perfusion, because now that it's coming from here to here, there's less blood going into the brain. So reduced cerebral perfusion on exertion of affected arm. Okay. So say this is on the left side, right? So the left arm's like doing stuff. So when it's doing stuff, it's going to require more energy. So it's going to pull more blood. So because of that, it will cause arm ischemia, obviously, because the blood's not going to be enough to take care of the oxygen demand. You'll have pain because of less oxygen in blood. You'll have paresthesia, vertebrobasilar insufficiency, so dizziness and vertigo, right? So more than 15 mmHg difference in systolic BP between arms associated. Okay, so this is important. So you'll get more than 15 mmHg of pressure difference in systolic BP between arms. So on this side you'll have like 120, and on this side you'll have like 135, right, of systolic. This is the difference between the two sides of the arms. Okay, the coarctation is between the upper extremity and the lower extremity, the difference, and in this you have it between the arms. It's associated with arteriosclerosis and Takayatsu arteritis. This is also vasculitis. Okay, and we need to know what that is too. It's an easy one to remember though, because you can think of Takayatsu being like a samurai with a sword that, in a battle he got his arm cut off, so he has different pulses on both sides now. Okay, so Takayatsu is also called TAC, is a rare form of vasculitis disease involving inflammation in the wall of the large arteries in the body, the aorta, and its main branches. The disease results from an attack by the body's own immune system causing inflammation in the wall of the arteries. Okay, so it's associated with that arthritis. Which one? Subclavian steel syndrome. And also heart surgery. It could be because of the scarring, the stenosis happened or something like that. Okay, just make sure that the steel syndrome, it steals the blood from the other side onto the side of the stenosis. So there will be less blood for the brain, so you'll have dizziness and vertigo. There will be not enough blood for the supply, right? So if it's going to the left arm, it's not going to have enough supply there. So you're going to have pain in that side of the arm. Most importantly, the blood pressure is going to be different on this one, because here it's going 120 mmHg on this side, right? And then over here it's going to get reduced because it's going through 1, 2, 3 turns, and that's going to reduce the thing. Pressure. Okay. Anginas. So ischemic heart disease manifestations. It's really easy to remember these if you remember the symptoms. Okay, so one of the symptoms is like the pain occurs on exertion. The other one occurs during rest. Okay, the one on the exertion, if it gets resolved with rest, it's gonna be stable. But the one where it occurs during rest is going to be unstable. Okay, and then you have vasospastic. That's that's a different thing altogether. So let's read about it. Chest pain due to ischemic myocardium secondary to coronary artery narrowing or spasm. Okay, so I'll try it here.
you have a heart, okay, and you have an artery supplying this thing. Okay, and this is the main artery. And let me draw the 1.2. Okay, so perfect. Chest pain due to ischemic myocardium. So these arteries are supplying blood to the myocardium. Secondary to coronary artery narrowing. So it could be that it's narrowed like this, right? So the blood can't go through to supply this area of the heart. Or spasm. It could be that this one's going spasming, so blood has a difficult time going into that artery, so it's just gonna avoid going into it, right? Just like a pipe that you move really fast with water coming out of it, and then you get slower water or reduced amount of water coming through it. Although there won't be any necrosis. Okay. Stable. So usually secondary to atherosclerosis, you have atherosclerotic plaque somewhere here. Okay. Stable. Usually secondary to atherosclerotic plaque. The symptoms are only going to occur if the occlusion it makes is more than 70% occlusion, right? Exertional chest pain in classic distribution. So this is the one with exertion, possibly with ST depression on ECG. Okay, so if you remember the ECG, it's gonna be like with a little bit of P wave, and then the P to Q, and then the Q wave, and the R, then the S, then the T, and T wave like that, and then the P wave again, right? So this area was the ventricular contraction or depolarization stage, right? And this T wave is the repolarization. So when they say ST depression, they're talking about this one. So instead of this, you'll have something like that. Okay, so that's a ST depression. Actually, let me just type it in here. Okay, so that's the ST segment depression. So why does that happen? That's basically because say the blood is traveling, right? The electrical impulse is traveling, right? And like normally what it does is it has to go through the whole thing, right? And that's what's causing this uprise and this. To go from here to here, it has to go through this whole path. But now that there is ischemia over here, it doesn't have to supply, it's not going to supply its electrical impulses there. So instead of going there, it's just going to go, like normally it would go like this, like it would supply all of this, and then it would end up here, right? But now, all it has to do is supply a little bit over here, and then over here, right? So that's a faster route it got from point A to point B, right? So that's a faster thing, or a faster route, I guess, for lack of a better term, right? So that's why you get a depression, because it was going, and then instead of supplying the area that would make this go up like that, it just avoided that, so it just ended up over here altogether, and it was faster. The signal was faster. In this case, what's going to happen? It goes down here, and it's going to get stuck here. So now it can't go through here or here, so there's nothing over there, right? So what it has to do is go around all the way, and then figure out where it's coming,
gonna come back from, right? So it's gonna go all the way, make all those things, and then find a way here, and then it's gonna end up here, right? And that's taking a lot of place. So that's why you get the ST elevation on ECG. Okay. So this is what the ST elevation is, because it's taking a lot more time, right? So you don't get this whole depolarization over here, because it's wasted that much energy. So that's why you get the elevation. Hopefully that makes sense. Okay. So again, stable. Usually secondary to the atherosclerosis, more than 70% occlusion, exertional dyspnea, exertional chest pain and classic distribution, possibly with ST depression on ECG, resolving with rest or nitroglycerine. So if it gets resolved because of rest or drugs, like nitroglycerine, it's going to be stable angina. Okay. This is common in no, not this one. This one's common in younger patients. Okay. Vasospastic. So vasospastic, also known as, actually, we only have 6 minutes. Let me try finishing this. So vasospastic, formerly presmental or variant, occurs at rest, secondary to coronary artery spasm, transient to ST elevation on ECG. Tobacco smoking is a risk factor. Hypertension and hypercholesteremia are not. Okay. So this is a risk factor that's important to remember for this. But hypertension and cholesteremia is not. Okay. Triggers include, because normally you would think it's because of atherosclerotic plaque, but it's not. Okay. So triggers include cocaine, alcohol, and triptans. Treat with calcium channel blockers, nitrates, and smoking cessation if applicable. Okay. But remember, high cholesterol doesn't have a thing for this. Okay, so here we had ST depression. Let me just do that. ST depression on ECG. Here we have ST elevation on ECG, and it occurs secondary to coronary artery spasm. Unstable thrombosis with incomplete coronary artery occlusion, with or without the ST depression and or T wave inversion on ECG, but no cardiac biomarkers elevation, unlike non-ST segment elevation in MI or STEMI. Increase in frequency or intensity of chest pain or any chest pain at rest. This is going to be the buzzword right here. That the patient was sitting and doing nothing and started experiencing some chest pain. Okay, that's what tells you that it's going to be unstable and not vasospastic or stable. Okay, now for stable, they'll tell you that he was mowing the lawn in the morning and then he started feeling chest pain. When they did an ECG, they found a ST depression on ECG. So then you just have to figure out that it's either stable or just stable or in non-STEMI, right? But for non-STEMI, they'll give you cardiac markers as well. Okay, so that's how you differentiate between stable and STEMI. For vasospastic, they'll give you a history of smoking, long-term smoking, and they might give you this to throw you off, but they'll then ask you, so what should the treatment for this person be, right? So besides giving the drugs, what lifestyle change should they make? So they'll have like a better diet or go exercising and all that. It's gonna be stop smoking. That's the one. For unstable, they'll give you ST depression and T-wave. If not, they will definitely give you that the person experienced chest pain while sitting around watching TV or reading a book or something. Okay, we'll come back after the break. Can you hear me, right? Yeah, okay. Again, stable, ST depression, chest pain on exertion, and it resolves with rest or nitroglycerine. an unstable chest pain during rest, vasospastic history of smoking. So stable angina, unstable angina, and NSTEMI and STEMI, right? So non-ST segment elevation myocardial infarction and ST elevation myocardial infarction, two different things. On pain, stable angina, it occurs on exertion. There won't be any troponin level elevation. That's the cardiac marker. It only happens when there is a myocardial infarction, so that's what we do for that. Infraction, none, and ECG changes, none. Okay, even though possibly it could have ST depression on ECG. Okay, but that's not reliable, I guess, because they'll give you that he was exerting himself and then he felt chest pain, so that's stable angina. But then it resolved after 15 minutes of rest. Unstable angina, mild exertion or at rest. Okay. Again, no cardiac markers. Infraction, none. EC changes are that possibly it can have ST depression or T wave inversion. Right? Inversion because it repolarizes faster, because there's less area that it has to repolarize. That's why it's an inversion. Okay. ST and STEMI. So that's non-ST segment elevation MI again. Is because it's going faster to the point B from point A, because it has less work to do. So that's why depression. Okay. Troponin level is going to be increased because that's a cardiac marker for MI. Infraction. This is subendocardial. So subendocardial is when it's, just this part, or like it could be, anywhere, but not the whole thing. It could go even closer to the edge, but not the whole thing. That's still subendocardial, because that still means it can go from point A, from point A to point B faster, because it has less work to do. But if it covers the whole thing, what does that mean? This thing, that means it has to go all the way around and work, right? So then you're gonna get ST elevation instead, and this is called transmural. Transmural means all the layers of the heart: epicardium, myocardium, and the outer one. Okay, so this occurs at rest as well, just like this. Troponin marker is also elevated. So only way you can differentiate between the two is if there's ST depression, which means the electrical impulse goes faster because it's less work. But even if it doesn't apply here, it still has to do more work to find a place where it can reach point B. So that's why it's transmural. So that will be ST elevation. Okay, coronary steal syndrome. So coronary steal syndrome is different than subclavian steal syndrome, but the only difference is that it's in a different place, and something can influence it. So how does it get influenced, right? So that's what we're gonna learn. Distal to coronary stenosis, vessels are maximally dilated as baseline. Okay, let me draw that. So we have a vessel here, and there's a coronary vessel, so it's kind of like that, right? So stenosis happened here, like that much, more than 70% occlusion, I guess. Okay. Administration of vasodilators. So this thing is also supplying this, and supplying this. Okay, So the coronary has branches like this, and here in one of the branches, it has, you know, so it's gonna pull here, and then it's just gonna go into this or into this side. Okay. So distal to the coronary stenosis, vessels are maximally dilated at the baseline. So distal to it, over here, is gonna be dilated. Okay. Not this, because this would be distal to the stenosis, and this would be proximal to the stenosis. Why? Because it doesn't have blood, so it needs more blood. So it's making room for more blood to come, and decreasing any amount of resistance as much as it can, right? So administration of vasodilators like dipyrimidamole or rigadonosone dilates normal vessels. Okay, so obviously we would think, okay, so what if we just dilate this vessel, right? Wouldn't that just make everything easier? But when you give vasodilator, what else is gonna happen? These are gonna get dilated as well, right? Like that. This one would get dilated, but again, the stenosis is still gonna apply, right? So this will cause blood is to shunt towards well perfused areas. So even though there's stenosis here, this is also decrease in resistance and decrease in the resistance times 2. And there's still going to be some amount of resistance here. So it's going to take a path of least resistance and go through this or this instead of going through here. Okay? So blood is shunted towards well perfused areas. So ischemia in myocardium perfused by stenosed vessels. Okay. Principle behind pharmacologic stress test with coronary vasodilators. So blood is shunted towards well perfused areas. This causes ischemia in myocardium perfused by a stenosed vessel. Okay, so what it's saying is that because of this, even though it was like this much, it was still getting perfused a little bit in this area, right? Because these also had like resistance before, some amount of resistance. So that allowed some blood to leak through here, from here, right? So at least a little bit was coming from here and perfusing. But now that there's no resistance here, there's nothing, making the blood go from here to here instead of just going here. It's easier for them. And they'll perfuse this area, they'll perfuse this area, and this area is going to now get, ischemic. Because hopefully that makes sense now. So this is called, coronary steal syndrome. They're stealing the blood from one vessel into the others when you give them vasodilators. And this is the principle behind physiologic stress test with coronary dilators, right? So they give you the dilators, then they make you do things, and then they check for, if it gives you pain or not. Because you're not going to get pain if you're just sitting around and you're at a doctor's office. You need to do the stress test. And that's how they figure it out, if there's a problem. Okay. Then you have sudden cardiac death. Death occurs within 1 hour of symptoms, most commonly due to lethal arrhythmia, for example, ventricular fibrillation, associated with coronary artery disease, up to 70% of the cases. Cardiomyopathy, which is hypertrophic or dilated, and hereditary iron channelopathies like long QT syndrome or Brugada syndrome. Prevent with ICD, intracardiac device. Okay, so what comprises of sudden cardiac death? It's when the death occurs within 1 hour of symptoms, and it's mostly due to lethal arrhythmia like ventricular fibrillation. It's associated with CAD. Okay, chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic cardiomyopathy. myocardial damage, myocardial hibernation, potentially reversible left ventricular systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. Okay, so chronic ischemic heart disease, it's just progressive onset of heart failure, or many years due to chronic ischemic myocardial damage. This is a important concept right here, myocardial hibernation. So it's, what is it? So potentially reversible left ventricular systolic dysfunction. Okay, so the dysfunction, it can be reversible. So they'll give you a question about a person who's suffering from progressive onset of heart failure, and initially when they were tested or like a biopsy was done, the cardiac cells had a few, I don't know, it had a dysfunction, but after like 2 months it started functioning normally. So what is this concept called? It's called myocardial hibernation. It's going to be similar to that kind of thing, the kind of question. So potential reversible LV systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, which is a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. So it's different from that. Okay, myocardial infarction, most often due to rupture of coronary artery atherosclerotic plaque. This will cause acute thrombosis, right? Increase in cardiac biomarkers, CKMB, erythropoietins. These are diagnostic. This is, the easiest concept to understand. Myocardial infarction. It's basically, instead of a stenosis, imagine this was a plaque, right? So this is the plaque in this artery, and this plaque, then maybe because of some friction or whatever, there was endothelium rupture, and the plaque, a little bit of it got loose, and then it traveled elsewhere. So most often due to rupture of coronary artery atherosclerotic plaque. This will cause acute thrombosis. This plaque will then further travel down into like the end of the artery and then cause it up there. So this will, when you have myocardial infarction due to this or any kind of ischemia, that's long lasting, or you'll have biomarkers like CKMB and troponin. We'll learn about that later. And if you have these, that means you have suffered from myocardial infarction, because this is how you diagnose it. So you have non-ST segment elevation or ST segment elevation myocardial infarction. Okay. Infarct location. So if you have lower ST, that means it's not all the way, right? So it's going to be subendocardial location. So layers involved are subendocardium, inner 1/3, especially vulnerable to ischemia. So okay, so this is where it happens. When I said it can go up to there, that wasn't true. Okay. It's only going to happen in the subendocardial layer. ECG changes, ST segment depression. Then you have infarct location here is transmural, all three layers. Layers involve full thickness of myocardial wall. ECG changes are going to be ST segment elevation, and you're going to have pathologic Q waves. So this is what the pathologic Q wave looks like. Normally it's lower than the S, right? That's the depression, I guess. And this is elevate. This is elevation, depression elevation. So let's just say pathologic Q waves are the ones in red. And yeah, okay, we got it. So in myocardial infarction, what happens after the thrombus occludes the supply, right? So commonly occluded coronary arteries are left anterior descending artery, right coronary artery, and then at the end you have circumflex artery, right? A branch of left coronary artery, not anterior descending, but right. So symptoms: diaphoresis, nausea, vomiting, severe retrosternal pain, pain in left arm and or jaw, shortness of breath, and fatigue. Okay, this is because of what? Phrenic nerve, I guess. 0 to 24 hours. So within 24 hours, what will you see in myocardial infarction? You'll see wavy fibers. So that's what it is, right? So you get dark mottling, pale, tetrasodium stain, occluded arteries right there. You have wavy fibers, 0 to 4 hours, and then you have early coagulative necrosis. So this happens within 4 to 24 hours, okay? The necrosis occurs at that time. Then you get cell content released into blood, okay? So when you have that, that's going to cause reactions, obviously. Then you have edema and hemorrhage. Reperfusion injury occurs. This is free radicals and increase in calcium influx. Hypercontraction of myofibrils, dark eosinophilic strips. Right. So eosinophil is always the first one that comes. So let's see if they have. Here you can see the fibers, I guess, right? No, it's not right. Yes, this is a better one. So you'll see wavy fibers like that, right? Necrotic myocytes that are being distorted by a pull of coagulated. But what I want you guys to see is eosinophils. I guess that's eosinophil as well. Okay, just pay attention when you get a question in UWorld, what this looks like, and like save the photo so you know what to look out for, because it's very important that you can distinguish between them. Because what they will do is they'll just give you a photo like this and they'll ask you what stage of myocardial infarction is this person in, and you need to know these stages, because the one we saw like this is not eosinophil, it's neutrophil. Okay, so if you see like a little bit of dots right here, and you can still make out the wavy fibers, right? So that's going to be 0 to 4 hours. Okay, so what can happen because of these? You can get ventricular arrhythmia, heart failure, or cardiogenic shock. Okay, then what happens after eosinophils? You get neutrophils. So in 1 to 3 days, you have extensive coagulative necrosis. Tissue surrounding the infract shows acute inflammation with neutrophils. Okay, this is complication is post-infraction fibrinous pericarditis, and you have redness in that area. Okay, that's what's going to cause it's called the hyperemia. Okay, so post-infraction fibrinous pericarditis. Important. First, you get wavy fibers, and coagulative necrosis starts, and reperfusion injury happens here, which is free radicals and increase in calcium influx. and you have hypercontraction of myofibrils, dark eosinophilic strips, and then 1 to 3 days you have neutrophils, and this continues. Also remember the complications; they test you on that too. So what is this person at risk of between 0 to 24 in the initial stages of MI? They're at risk of having ventricular arrhythmia, heart failure, and cardiogenic shock. Here they have it's post-infarction fibrinous pericarditis, and then within like the first week or the second week, right? So after neutrophils come what? Macrophages. Then granulation tissues at the margin. Okay. So you have hyperemic border, central yellow-brown softening. Okay. And at this point, you can't make out any fibers, right? Not the wavy fiber, not the straight fibers either. None of them. It's just everything is just haphazardly placed. Okay. Free wall rupture, tamponade, pulmonary muscle rupture, mitral regurgitation, interventricular septal rupture due to macrophage-mediated structural degradation. This leads to left to right shunt. So LV, pseudoaneurysm, aneurysm, risk of rupture. So this is the important one right here, pseudoaneurysm. There's a risk of rupture here between the first and the second week after 3 days. So since it's soft and stuff, how are you going to remember this? So macrophages come in. That you gotta remember, free wall rupture is during this period of time. It can cause tamponade. That's just fluid in the spaces between the layers of the heart, pericardial space. Papillary muscle rupture. Okay, these control the valves, right? They're the foundation of the valves. So you can get mitral regurgitation. Then interventricular septal rupture can occur as well. So between the two ventricles, this is due to macrophage as well. Okay, so macrophage mediated structural degradation. So this can cause left to right shunt. So the blood to go through the septum. Okay, and LV, pseudoaneurysm, risk of rupture. So when does this go away? After 2 weeks to several months. Okay, when you get the scar over there. So the scar is going to look gray and white. It's not going to be red anymore or yellow brown. Okay. This is what the scar looks like. You can't make out any muscle fibers here. All you see is like a blank slate of pink ocean, right? With a little bit of dots in the middle. Okay, so you can get Dressler syndrome, heart failure, arrhythmia, true ventricular aneurysm, and risk of mural thrombus. They didn't get what Dressler syndrome is. This is an important one. So, it's the inflammation of the space surrounding the heart. Pericarditis. It's believed to be an immune system response after damage to heart tissue. Okay. So the first thing you can get in the complication is reperfusion injury, then the free radicals, then the dark eosinophilic strips for this one. Over here you can, post-infarction fibrinous pericarditis. Then here you have free wall rupture on every side. On left ventricular wall, you can have it in the septum, or you can have it in the muscles that control the valves. And here you have Dressler syndrome and immune response. Okay, you can have heart failure with arrhythmias, true ventricular aneurysm as well. So you have a risk of mural thrombus, contracted scar, completed after 2 weeks to several months. Eosinophil strips, neutrophils, macrophages, then the collagen fibers. So how do you diagnose it, right? So what is troponin or CKMB? That's what we're gonna learn about here. So in the first 6 hours, in ECG is the gold standard. If a person comes in with chest pain or pain in their arm and back or jaw, anyways we do ECG for that. So next thing you can do is cardiac troponin 1 rises after 4 hours. So you can do troponin levels. You can check that. So it rises after 4 hours, peaks at 24 hours, and is increased for 7 to 10 days in your body. Okay, after heart attack. More specific than other protein markers. So this is troponin. The levels rise up to here, and then it goes down and like that. Right. So you're pretty good until like over here at least. And even if there's like a minor level, there is a threshold. So if it's above that line, it's valid. Then you can have CKMB increase after 6 to 12 hours, which peaks at 16 to 24 hours, and is predominantly found in myocardium, but can also be released from skeletal muscle. So just like in rhabdomyolysis, you have creatinine, right, kinase leaking into your urine. You can pick it up and test for it over there. Here, if it's the heart muscles, it's going to be CKMB. Okay. So it increases after 6 to 12 hours and peaks in at 16 to 24 hours. Why is this important? It's useful in diagnosing re-infraction. So say a person already had infraction, he comes in and then he says while he's under your care that he's feeling this or he felt this last night and stuff. Then you'll do this again, CKMB, to check for re-infraction following acute MI. Because levels return to normal after 48 hours. Okay. So right where that line crosses, below the threshold, that's when it starts. Then it's not considered anymore. So if there's another rise after that, that means there's re-infraction. Okay, so troponin, and you can detect it up to 10 days. And then for CKMB, you can detect it up to 2 days. ECG is the gold standard. ECG changes can include ST elevation for STEMI or transmural infract, or ST depression, that's end-STEMI, subendocardial infract, hyperacute peaked T waves, or T wave inversion, and pathologic Q waves or poor R wave progression, evolving or old transmural infract. Okay. Now the fun stuff. ECG localization of STEMI. So infract location and leads with ST segment elevation or Q wave. If you're the kind of person that thinks they would never get this, that's okay. You can just memorize this. That's all you need for step 1. You don't have to worry about the leads or where it goes and all that stuff. You just memorize this right here, and that's what they'll give you. They'll tell you that MI in leads 1 and AVL, right? So that's going to be your lateral. Or they'll tell you that there's detection of MI, ST elevation in the leads from V3 to V4, right? So that'll be your anterior apical and distal LAD, okay? But for people who can pick it up, I'll just go over it real quick. Okay, so you put so imagine this is the heart, like a person, you cut through him on a coronal plane, and then you have sternum here, so this would be your anterior side, right? So if you just imagine this on yourself, the sternum, and right behind it is the heart, and this is the right side. So on the right side of your sternum you have V1, okay, and the left side you have V2, and then just keep going, V3, V4, and now you're at your sides, or your lateral sides. You have V5 and V6 over there. Then this is where normally it ends in, like, as long as, like, if you have done internship or any kind of rotations in a hospital. Sometimes if you are at a fancy hospital, they could have V7, V8, and V9 going all the way back. Okay. So if something is detected, ST segment elevation, it just means the electrical impulse taking time to reach these leads, and if it reaches them faster, you're gonna get elevation. If it reaches them slower, you're gonna get a depression. Okay, that's what it means. Okay, and then you have these leads. So AVR, AVL, and AVF. F is for foot, L is for left, okay, and R is for right. So foot, if AVF is involved, it's always going to be something inferior. It could be antero-inferior, it could be latero-inferior or something, I don't know. But inferior is going to be involved, like inferior side of the arm. So between AVR and AVF, so if you just like pull out your arm, that's your AVR, the right arm, and then your foot, and between that is going to be 3, and then if you pull out your left hand, and between that and your foot is going to be 1 near the arm and 2 near the foot. Okay, so that's how that is. Now that we know that, what does that mean? Normally we just look at the second lead, right, because that's the one that's closest to the heart, with the right ventricle right behind it, right? So you get the maximum, optimum results with that one in that lead. So you have your P wave QRST, PQRST, PQRST, and it has around 30 and 0.5, so that's how many beats? So first one was 300, then 150, then it was 100 for 3, right? And then for 4 it was like 75, 60, and 50. Okay. So it's normal. It's less than 100 heartbeat. Then you have the first one, right? So that's this side. So first, second, third. So first, second, third is right there. This is all your inferior side, right? Because AVF is involved. So 2, 3, and AVF is going to be inferior. So if we look here, inferior side is supplied by marginal branch of right coronary artery, right? Let me go back and bring that up. It was in anatomy. Right here. Okay. So the inferior side is supplied by the AMA. AMA is the acute marginal artery. It's the branch of right coronary artery. So inferior right coronary artery. So that's 2, 3, and AVF, right? So AVF is your inferior one. That makes AVL the lateral one, right? So the lateral AVL. So if you have AVL involved in anything, you're gonna have lateral. But what else is lateral? So is V6 and V5, right? And 1 and AVL. So you're gonna have that in green. So 1 AVL, 5 and 6. If you have any kind of abnormality in the ECG in these leads, it tells you that it's somewhere on the lateral side, right? So lateral is left circumflex artery. Okay, so that's this thing right here and that thing right there. It turns into obtuse marginal artery as well. Okay, and it's a branch of left coronary artery. So left circumflex artery, lateral. If you have uh, ST elevation or something on lead 1 and AVL. L for lateral, L for left. Okay. And here you have 5 and 6. Again, anterolateral. So anterior side, remember that's left anterior descending artery. So it could be that, because since it's also a branch of left coronary artery or the left circumflex artery, so it's coming from there as well. Okay, so it could be a thrombus here coming from here, and then it will affect here, or it can be a thrombus here, and that's still gonna give you a problem in V5 and V6. Okay, so we just finished 3 of those. So if you have a problem in V5, V6, it's your lateral sides. So LAD or LCX, or it could be lateral. So why am I not making too much of a difference, or why are both of these green? It's because they both are supplied by left coronary artery. Okay, that's the most important thing to remember. They won't ask you where did this thrombus come from, and you're not gonna say left circumflex or something. You're gonna say it came probably from left coronary artery because that's the one it's branching out of, right? So that's where it came from. Then they can ask you, okay, so they checked why angioscopy or whatever, and that the thrombus is in left anterior descending artery, but the left coronary artery was found to be clear. Like, so how did that happen, right? Or sorry, posterior descending artery, right, the inferior side. So how did that happen? And RCA was cleared. Like, it wasn't because of RCA. So it's because of either codominance or the left dominant heart, right? So it's being supplied by left coronary artery or left circumflex artery, like that. So know the difference between that. Okay, so we did anterolateral. So that's left descending or left circumflex. We did the lateral and we did the inferior. Now we will do V3 and V4. So we have V3 over here between the sternum and the lateral, right? So it's right under the so V4 would be right under the apex, the mitral, the heart apex, and between that and the sternum you'll have V3 and V2. So V3 is right between V2 and V4. Okay. If you have done ECG, you know this already. So V3 and V4 is right there, the oranges, and this is on the interior side, right? So it's going to be the interior and apical, because that's the apex or the apical region of the heart, where you can feel the heartbeat with your apex beat, right? So distal LAD, this area is supplied by left anterior descending artery. That's why it's antero. Okay, and V3 and V4, that's where you'll see it. ST segment elevation. So if you see it over here, there's a problem with this area of the heart, basically the anteroapical area of the heart. Then V1 and V2, right there and there. Left anterior descending artery, anteroseptal, left descending artery. So V1 is on the right side of the sternum and V2 is on the left side of the sternum. So anterior side and the septal sides. Okay, so again, this is left anterior descending artery. So left anterior descending artery supplying the anteroseptal, anteroapical, anterolateral, and lateral. Okay, the inferior side is supplied by the RCA, and the posterior side, as the name implies, is pushed by posterior descending artery. This is your V7 to V9. So V7, V8, and V9. This is your scapula. Then you have ST depression in V1 and V3 with talar waves. Okay. So you might pick it up with these as well if there's a infraction over here on this side. With tall waves over here. Because it's taking so much time to go around. From here to here. Right. So that's why it's the tall wave. Okay. That was ECG. Normally, they'll just give you all of this, and all you have to focus on is the lead 2, the second lead. And that will most probably tell you what the problem is, anyways. Because they'll tell you which area it was. You might have to figure out which area is supplied by what. Most of the areas are supplied by left coronary artery. Only the inferior is RCA. Right. The PDA is also a branch of RCA, right? But it could be a part of LCA as well, depending on which dominance it is. Okay, narrow complex tachycardia. For this, atrial fibrillation. I don't think it's in the old book. Oh, there's a. So there was we'll just go through it. Atrial fibrillation, irregular rate and rhythm. This is the buzzword for atrial fibrillation. Okay. 2 I's in irregular and 2 I's in fibrillation. Okay. We don't talk about this one. So 2 I's in this and 2 I's in that. Irregular rate and rhythm. Okay. 2 R's as well, but that applies to the other one. Rate and rhythm with no discrete P wave. That's the most important one. You can't make out which one is the P wave, right? Because they all look up and down and different sizes, and that could be T wave or P wave, but you can't be sure. So no discrete P wave. This whole thing is a buzzword right here. If you hear anything from here or like this sentence, it's going to be atrial fibrillation. Okay, so common risk factor include hypertension and coronary artery disease, may predispose to thromboembolic events, particularly stroke. Management is rate and rhythm control, cardioversion. Definitive treatment is ablation of pulmonary vein ostia or left atrial appendage. Consider anticoagulation based on stroke risk. Right. So why this? Remember when we were doing anatomy of heart, I told you that this is where the atrial signal goes to on the left side. Right. When we were doing this. Right there. So from SA node, it goes to the other atria over here. So that's where it goes. And that's what causes the atrial fibrillation. So we deal with that area. So that's why definitive treatment is ablation of pulmonary vein ostia. So right there, that's where pulmonary vein comes in. Or left atrial appendage. Consider anticoagulation based on stroke risk. So this is also important because after atrial fibrillation, a person who suffers through it, after a few days or months, they suffer from stroke. Why? It's because during fibrillation, the blood was being stagnant in the chambers, and when the blood is stagnant, what happens? Clot form, right? So there was some clotted blood, and now that it's on this side, it doesn't go through the lungs, where embolus can, cause more problems. So this will go into LV and through aorta into the coronary, like carotids, then coronary, cerebrals, and it can cause ischemia or stroke over there, right? The most common site is what? It's between, I think, anterior cerebral artery and the middle cerebral artery. We'll do that in neuro, circle of Willis, but if you want to look it up. Okay, So you have to consider anticoagulation based on a stroke's risk because of that. Okay, so may predispose to thromboembolic event, particularly stroke. So when you're looking at an ECG, the boxes between the RRs are going to differ in all the region, like all the sections of all the RR sections, basically. Okay, so RR1 will not equal to RR2, which won't equal to RR3, won't equal to RR4. Irregular baseline, absent P waves. Okay. Then you have multifocal tachycardia. Okay. Multifocal atrial tachycardia. This is irregular rate and rhythm with at least 3 distinct P wave morphology. Here, the P waves are distinct, right? You can tell which one's P wave here. Here, you couldn't tell it. Okay. For tachycardia, you should just remember that you can just read the boxes between them, and it's going to be 3 or less boxes between RR. Okay. So this is one box right here. The 5 small boxes. You don't read the small boxes. You read the big boxes. So that's one box and a half. Okay. So like that. So even if it was 2, it's still 150, which is more than 100. Okay, so irregular rate and rhythm with at least 3 distinct P wave morphologies due to multiple ectopic foci in atria. It's associated with underlying conditions such as COPD, pneumonia, and heart failure. Okay. Sorry. Okay, so P waves will be short, tall, inverse, whatever in this. It's because the AV node is getting its signal from another place other than the atria SA node. That's what it means. So due to multiple ectopic foci in atria. Okay. Then you have atrial flutter. The flutter is rapid succession of identical consecutive atrial depolarization waves causing sawtooth. Okay, if you see this, it's going to be a flutter. That's the easiest one to figure out from an ECG. Sawtooth appearance of a P wave. So if you ever seen someone work a saw in cutting a wood, the saw blade, this is what it looks like. So that's what they mean by sawtooth. Treat like atrial fibrillation with or without the catheter ablation of region between tricuspid annulus and IVC. Okay. What's over there? So tricuspid is right here, and IVC is around here. So I guess that's where like majority of the ectopic comes from, I guess. Just remember that this is where you do it, because they might ask you that. Proximal supraventricular tachycardia, most often due to a re-entrant tract between atrium and ventricle, most commonly in AV node, commonly presents with sudden onset of palpitations, lightheadedness, and diaphoresis. This is an easy one to guess from a question stem. Okay. Treatment, terminate re-entry rhythm by slowing AV node conduction. For example, vagal maneuvers, right? It's called vagal maneuver, but it's actually you doing the carotid sinus thing. Or you can give IV adenosine. Electrical cardioversion if hemodynamically unstable. Definitive treatment is catheter ablation of the re-entry tract. and this is the most important one, because they'll give you an ECG, and on the lead 2 you'll see this happen, and if you see this happen, it's Wolf Parkinson White syndrome, or WPW syndrome. Most common type of ventricular pre-excitation syndrome, abnormal fast accessory conduction pathway from atria to ventricle, bundle of bypasses rate slowing AV node. This will cause ventricles partially depolarize earlier, which leads to the characteristic uh, delta wave with wine QRS complex and shortened PR interval. Okay. May result in re-entry circuit and supraventricular tachycardia. Treatment is procainamide and avoid AV nodal blocking drugs. So what's happening here is that since the AV node, before it can go and do this, there's another another thing. Hold on, I think I have a photo for this. Okay, right there, right? So AV node can do this and do that, right? So SA node goes to the AV node, and that goes to the bundle of His, and then through the ventricles. But in re-entry, it's this thing. So it goes like that, and it goes from another place, and then it excites someone over there as well. So this causes early excitation. So there's early excitation, so the PR interval between will be short. However, since it also get excited by this AV node, it takes some time to repolarize, right? Because otherwise it's going to get fatigued. So while it's repolarizing, if you do another one, it's just going to take a little longer time to cause contraction. So that's why you're going to have a wider QRS wave. Okay. So results in re-entry supraventricular tachycardia. Even though it's happening as soon as it's relaxed, repolarized, there will be wider QRS, so wide QRS complex and short PR interval for WPW. You gotta remember that one, and you gotta remember ectopic foci. Okay, 4 minutes. I can discuss more about this. SVT, you gotta know how to figure it out. So here there's only one box, so that's 300 beats per minute, right? Now you see ST elevation, the T wave and P wave are overlapping each other, so you can't differentiate it between them. Then you have multifocal atrial tachycardia, so you have P, but the P wave is not the one that's causing the QRS anymore. It might at some point, but mostly it's coming from another place, not SA node to the AV node. Okay. Fibrillation, RRs are different, everything is different. You can't make out P wave. Here you can make out P wave, but you have a sawtooth, and the RR is equal to RR2 and RR3. Here the RRs are different as well, but you can make out P wave. Here again, one box, 300. You do vagal maneuvers and IV adenosine. I guess that's why people pick vagus nerve, because it's called a vagal maneuver, but it's actually glossopharyngeal that takes the afferent fiber to the brain into the solitary nucleus, right? Then WPW syndrome, delta wave. Okay, I'll take a break.
Cardias, right? Arrhythmia and description and ECG findings. Ventricular tachycardia VTAC. Typically regular rhythm. Rate is more than 100. QRS is more than 120 milliseconds. Most commonly due to structural heart diseases, for example, cardiomyopathy or scarring after myocardial infarction. High risk of sudden cardiac death. That's the one, but death after 1 hour of cardiac symptoms. So
there's like one and a half box there. Right, so one and a half box there, so it's more than 100 anyways. Then we have Torsade de Pointes. Torsade de Pointes. So this is what the ECG would look like, and if you were to draw imaginary blue and imaginary pink line around it, it would look like this, like a helical DNA, right? So it's not called helical type DNA, it's actually called Torsades de Pointes, right? Polymorphic ventricular tachycardia, shifting sinusoidal waveform. Many progress to ventricular fibrillation. Long QT interval predisposes to Torsades Pointes. Caused by drugs, decrease in potassium, decrease in magnesium, and decrease in calcium. Right? So what would that look like in an ECG? So they would give you this, and then they'll ask you, or they might tell you that it's this, right? So it's big and small, right? So small and big. So if you were to draw a line like that, that's what it would look like. Or like this too. So this was his Torsade de Pointes as well. So learn to recognize that. Right, so if you would draw a line like that, similarly, it would be this. So they'll ask you, what would you see on ECG in Torsade de Pointes, or because of these drugs, you would see a long QT interval. That's what they're looking for. Okay. It's caused by drugs and also decrease in potassium, magnesium, and calcium. This is twisting of points. Treatment is magnesium sulfate. Drug-induced long QT, right? So long QT is because of A, B, C, D, E, F plus NO. Okay, so A for arrhythmias or antiarrhythmics, right? 1A and 3, or arsenic. B for biotics, antibiotics, macrolides, and fluoroquinolones. This is important because you give these a lot, right? It's pretty common to prescribe these, so know about that one. Antipsychotics like haloperidol, chloroquine, antidepressants for D, and diuretics as well, like thiazides, antiemetics like ondansetron, and antifungal fluconazoles, Navier protease inhibitors, and opioid methadone. It's quite easy to remember, so remember these just like you would remember cytochrome P450 inducers and inhibitors. So this is also important to know. Ventricular fibrillation. Okay. Know the difference between the two ECGs. Okay. It's important to know the difference between, because they look a lot similar. So here, disorganized rhythm with no identifiable wave. Okay. And treatment is fatal without immediate CPR and defib. Okay. Conduction blocks. So for conduction blocks, in the old book they had this mnemonic that you could have used. So if the R is far from P, then you have a first degree, right? So first degree AV block, that's prolonged PR interval. So this is the PR, right? The start of P wave and, the R, I guess. So the start of P wave and R is long, but it's equal to each other sections of PR. Okay. So prolonged PR more than 200 milliseconds. Treatment is none required. It's benign and asymptomatic. Okay. You still have the this. You have a little U wave over there, then P wave again. Okay. Then longer drop, then you have a Wickenbach. Okay, so second degree AV block. Uh, this is Mobitz type 1, also known as Wickenbach. Uh, Progressive lengthening of PR interval until a beat is dropped. Okay, so here PR1 is going to be lower than PR2, which is going to be lower than PR3. So PR3 is more than PR2, more than PR1. Right. So, and then you don't have ventricular depolarization at all after this. So P wave is there, but absent QRS, right? So longer drop, then you have a Wickenbach. Okay. If some P's don't get through, then you have Mobitz 2. So Mobitz type 2, that's drop beats that are not preceded by a change in PR interval. May progress to third degree block as it usually indicates a structural abnormality such as ischemia, fibrosis, or sclerosis. Treatment is usually a pacemaker. Right, so you see PR interval there, PR interval here. Here you see a P but no QRS, right? But this one is equal to this, so the P's are equal. Here it was less than this, and which was less than this, right? So again, if some P's don't get through, then you have Mobitz 2, right? So drop beats that are not preceded by a change in PR interval. May progress to third degree block, so we'll read about that, as it usually indicates a structural abnormality such as ischemia, fibrosis, sclerosis. Know these. Again, if the R is far from P, then you have first degree. Longer drop, then you have a Wickenbach. If some P's don't get through, then you have a Mobitz 2. And if P's and Q's don't agree, then you have a third degree. Okay. Okay. So third degree is a complete or AV block. Here you have the distance between P and P is the same as is R and RR complexes, right? However, RR does not correspond to the P's and the P's don't correspond to the R's, okay? So P waves and QRS complexes rhythmically dissociated. Our atria and ventricles beat independently of each other. Atrial rate is more than the ventricular rate, may be caused by Lyme disease. Lyme 3, right? LYM3. Treatment, usually a pacemaker for this as well. That's the easy one to understand because P is equal to P, so you can just count the boxes between them. So 1, 2 and a half. Again, 1, 2 and a half. 1, a half, 1, 2, 1, 2 and a half. Right, so if you keep going like that, and this one has like 3, 3, 3, so 9 and a half, and 3, 3, 3 and a half, so 9 and a half again. But QRS is not going to be after the P wave, it's going to be by itself. Why? Because when you have a block like that between SA and AV nodes, ventricle actually beats on its own due to signaled by his bundles. Okay, so let me write that out. In case of AV degeneration, signals from his bundles pretty much takes care of that. Then you can have bundle branch Brock. Remember, like in the heart, it goes to bundle branches. Interruption of conduction of normal left or right bundle branches, the fascicles. Affected ventricle depolarizes via slower myocyte to myocyte conduction from unaffected ventricle, which depolarizes via the faster His-Purkinje commonly due to ischemia or ischemic, for example, MI, or degenerative, for example, cardiomyopathy or infiltrative disease changes. That's just that. Nothing to explain there. Premature beats, arrhythmia description and ECG. Arrhythmia description ECG. Okay. So premature atrial contraction. When you have this, there's an extra beat arising from ectopic foci in atria instead of the SA node. So often secondary to the increased adrenergic drive, for example, caffeine consumption. Benign but may increase risk for atrial fibrillation and flutter. Narrow QRS complex with preceding P waves on ECG. They'll give you a good history for this so you can figure out that it's this and not, WPW or something like that. First of all, you gotta figure out it's in atria and not the ventricles, right? You have the beat here, and you have it here, here, and here, and here. So what you're having is normally the P wave is lower than the R wave, right? I mean S wave, T wave, sorry. Right, so the P wave here is smaller than the T wave, right? But say there's a synergistic, right? There are two P waves, or two SA node, or two P waves, which is atrial depolarization. So it's happening because of SA node and the ectopic node. You will have a P wave that's the same height as the T wave, right? So that's why it's up there. It's the same height as that. It's not smaller. So that's how you know that it's an extra beat when you're looking at a ECG like that. You gotta compare the P waves. Like here, P wave is smaller than T, P wave is smaller than T, and all of them, that's what you see, right? That's P wave smaller than T as well. These are P waves again. T only happens if there is QRS, right? So you don't see it everywhere. So if T wave follows a QRS complex, but if there's no QRS complex, you can just assume that it's a P wave. Okay. Again, same thing here, smaller and smaller, and everything except for this. It's even higher in this one, and higher in this one, same height as this one. So that's extra beat arising from ectopic foci in atria instead of the SA node, often secondary to increased adrenergic drive, benign but may increase risk of atrial AFib or aflutter. Narrow QRS complex with preceding P wave on ECG. Premature ventricular contraction, ectopic beats arising from ventricle instead of the SA node. So you have a shortened diastolic filling time and decrease in stroke volume compared to a normal beat. Prognosis is largely influenced by underlying heart disease. You'll have a wide QRS complex and no preceding P wave on ECG. When you don't have a P wave, you know that the QRS that's happening is because of something else other than the SA node signal, right? So you have there's a P wave right there,